this up. Good afternoon, everyone. Good afternoon, respected faculty, our esteemed guests, speakers, students, and my dear colleagues. I'm Dr. Prachi Pawar. I'm Assistant Professor in Medicine, and it gives me great pleasure to extend my warm welcome to everyone for today's CME titled Revisiting Diabesity with the Experts. This has been conducted by the Department of Medicine and is organized under the esteemed KJ Somaiya Medical College and Hospital. Today, we shall be focusing on a condition that has been quietly transitioned from being a comorbidity to becoming a clinical epidemic, that is diabesity. Diabetes and obesity are no longer parallel problems. They are deeply intertwined pathophysiologic entities. Diabetes and obesity will not just be dealing with raised blood sugar levels and raised BMIs. We are actually dealing with managing insulin resistance, chronic inflammation, cardiovascular risk factors, metabolic syndrome, and long-term organ damage, often in the same patient at the same time. What makes diabesity particularly challenging is that it presents itself very subtly. Sometimes a few kilograms gained here, sometimes some elevated HbA1c there, until it's full-blown number on a paper and a lifelong disease trajectory. India, unfortunately, is the epicenter of this metabolic storm. And as clinicians, we encounter these patients every single day in our OPDs, wards, ICU, and even during preventive health checkups. Yet, despite updated guidelines, newer drugs, and evolving evidence, translating this knowledge into practical patient-centered care remains a challenge. Today's CME has been designed to bridge that gap. We will be revisiting core concepts and discussing real-world clinician problems and decision-making in diabesity. Today, we have amongst us some of the sharpest minds in medicine. And I'm confident that each one of them have been doing their work in changing people's lives. I'm confident that our esteemed speakers and interactive discussions, this session will not only refresh our knowledge, but also refine our clinical approach and will address one of the most pressing health clinical challenges of our time. Before we begin the scientific program, I'd like to take a moment to express my gratitude from a place of deep respect. Some contributions don't go unannounced on stage or they don't get printed in brochures, but they get carved into lives of the students, the strength of a department, and the silent progress of a medical institution. She is a powerhouse of knowledge, grace, and dedication, and having spent over 30 years healing patients and shaping young minds in the field of autoimmune disease, arthritis, musculoskeletal disorders, and the entire medicine. And I request our beloved Dr. Niharika Gill, ma'am, to please address and welcome the dignitaries and delegates.
A warm welcome to all of you all, and I declare the CME open. And before I start, I would like to say something more. We have two stalwarts. One is Dr. Yevlekar sir, the hypertension person, and Dr. Vijay Panikar sir, who is like authority on diabetes. And for a moment, I'll take some time here that I would like to say that we are planning to start a diabetes OPD, which was always there, because when Dr. Panikar sir was there 25 years back, we had lots of patients. After sir left for some reason, and now we have a diabetes OPD, which is being carried by Dr. Nikhil Kulkarni. See, I had just attended a Mayo Clinic conference, and what I realized that we should be having what we call as a consultative medicine OPD only for diabetes, so that we can have a multidisciplinary approach. So we'll have a dietitian, we'll have a nephrologist, cardiologist, so that when the patient comes to this OPD, so we give them a complete holistic treatment. And so that's what on my mind before I thought about having a OPD, diabetes OPD with obesity. And obesity is basically I should be saying, is the health hazard. And it's not no more a disease. It's a disease per se. Like we used to always say he's fat, but now it is a disease, and we have an ICD code for it. And obesity has led to many different medical problems, and with this OPD, so we are looking forward for all your support and giving a holistic approach to our patients who really need our best care. Thank you for it.
Thank you for being an inspiration, ma'am. We are truly blessed. Now I'd like to introduce a leader whose vision, integrity, and commitment to the academic excellence continue to shape the future of our institution. Our dean is not only an accomplished academician and administrator, but also a guiding force who consistently upholds the core values of medical education, ethical practice, and patient-centered care. I would request Dean ma'am to please come on the stage and say a few words.
A very good afternoon to one and all, respected dignitaries, esteemed faculty, dear students, and of course colleagues. And I don't know where to begin. Actually, we have an extremely professional and senior team of speakers here, and they're all stalwarts in their own, of their own. And some of them have even been my teachers, so it makes me a little bit nervous to be standing here today. But on behalf of KJSMC, KJ Somaiya Medical College and Research Center, I welcome all of you to today's CME on diabetes. Diabetes and obesity, as madam said, are interlinked, and they are increasing at alarming rates. And they lay a special responsibility on us as healthcare professionals, not only to manage the patients and their complications, but also to focus on lifestyle changes and prevention in the first place. That's where we have reached now, so prevention has to be the goal. So I'm confident that today's CME, led by our esteemed faculty and distinguished speakers, will provide valuable inputs on not only the management, but also clinical dilemmas and a holistic approach to patient care. So I urge all the students in particular, please feel free. They are very, very senior, but please feel free to discuss your diagnostic dilemmas, your daily cases that you see, and any questions that you have, feel free to ask questions, and I'm sure it's going to be an academic treat. So without taking much of your time, I wish you a fruitful session today, and I congratulate the medicine department for taking the initiative to plan and conduct this CME today. So congratulations.
I would request Dr. Niharika Gill ma'am to felicitate Dean ma'am. Ma'am, please be seated on this. Thank you for your inspiring words, ma'am. May I now request our dynamic CEO, Dr. Manisha Bobde ma'am, to kindly address the gathering.
Very good afternoon. Welcome to each and everyone over here for the most awaited CME on this diabetes, which has been really led very well by the medicine department, which has made the most, not only the stalwart, I always say it, these are my heroes, okay, which are really working always on floor and serving to the community, contributing to the healing of each and every patient. Welcome to each dignitary, but I would like to mention few names. Welcome Dr. Panikar, welcome Dr. Evlekar, welcome Girish, welcome. It is a CME is always nothing new to us. Every one of us has been really attending multiple CMEs. The special about this CME is, which you will witness soon, As we keep on learning a lot of the new therapies, new guidelines, what are the evolving things in the diabetes, which is not only a simple metabolic disorder, but it has become a health issue, health hazard, which is really targeting all the organs of the body, affecting our lifestyle, and which is very much curable, which is very much within our reach to control it and live a very healthy lifestyle. And I'm sure in the CME, you will really take home a very fantastic messages from our good heroes, one who have come here to address you all. And congratulate Mayur for taking a ultimate expertise. It deserves a really a good clap. We all are here, right from fantastic food to arrangement to get this great heroes over here. The credit goes to him along with entire department. Just enjoy this CME to the fullest level. Once again, wish you enjoyable CME in this tenure.
I would request Dr. Mayur Mewada sir as the organizing chairperson for today's CME to felicitate CEO ma'am. Thank you for your inspiring message and constant support towards academic endeavors like the CME, ma'am. I would now like to welcome our chief guest, Dr. Vijay Panikar sir, and it is my proud privilege to introduce an eminent clinician like him, an inspiring academician and a leader whose contributions have shaped medicine practice. Please, sir, I would request you to grace the dais and speak a few words.
Hello, yeah. Good afternoon. It's indeed a pleasure to be here in Somaiya after 10 years. Actually, I miss Somaiya. In fact, after my rounds every day in the hospital, our entire staff and medicine department would go down to Shetty's canteen and have something before I left. So Shetty remembers me, he just came and met me and went. So it's wonderful to be here. This thing about starting a diabetes and obesity clinic, that's the in thing today. Obesity is on the rise, and today fortunately we have medications which can do wonders to these patients. So having a dedicated obesity and diabetes clinic is the thing, and I think Niharika has seen the writing on the wall and she is trying to implement it here. I think full marks to her, and I hope you do very well in this venture. We used to have a diabetic OPD here that time, but then I think subsequently after I left it stopped. But I think it's a great endeavor. I'll be speaking to you later also. Thank you.
I would request Dr. Gill ma'am to felicitate, sir. I would now like to welcome the first special guest for today, Dr. M.E. Yeolekar sir. Sir is a name that commands respect not only for clinical excellence, but for unwavering commitment to teaching, leadership, and service to the profession. With decades of experience and multiple leadership roles, sir has influenced everyone. Sir, please.
Thank you, Dr. Mayur, Madam Gill, CEO, Dean, all the dignitaries. I am very happy to be here. Maybe some of you or many of you may not know me, but I was at Somaiya from 2012 to 2020 for 8 long years till COVID asked me to sit down. So I am very much a Somaiyite. I am familiar with the hall, the people, the students, postgraduates, staff, and everybody. Now today is a special occasion in my opinion for the simple reason. that obesity has drawn attention of the whole world. And the reason is very simple, that we all know that the biggest crisis in medicine at the moment is called as the metabolic crisis. We used to talk of different things, hypertension, diabetes, coronary artery disease. And now we know that it is a spectrum. It is a continuity. It starts with fatty liver, thereafter glucose intolerance, thereafter hypertension, and eventually CAD. Now today's topic is diabesity. Because I am a former dean and director, I also consider some public health aspect. And when you use the word diabesity, it means you have lost half the case. Because things start with obesity and eventually over a period of time result into diabetes. So now we are talking of diabesity a bit later, because the precedent, the antecedents are sown inside the human body, human physiology much before that. And therefore, if you want to attack the obesity first in the community, in the clinic, and also in this special activity where every diabetic will get a full round attention. And you know, these days the clinical exam is slowly going down and down. And I tell people in my practice, because many patients come to me with reports, I said, I don't treat reports, I treat patients. It's extremely important that we first examine the patient and thereafter we try to interpret the reports in the context of his clinical condition. So that is one special message, because I see many youngsters over here. Don't be exclusively laboratory and technology dependent. Last thing I will tell you, some medical representative used to give some material to me, and medical student, doctor, iska kya karne ka hai? And that was a small hair to touch the sensory system in a diabetic related to peripheral neuropathy. So MR told me, when I am giving this to doctors are asking me what to do with it. So this is the, in a way, sad story, but I am so happy, and I must thank Dr. Mayur, Dr. Gill Madam for inviting me to this special occasion, and I must say that you are answering to the need of the times. Obesity, diabetes, and a specialized clinic. The last thing I would like to share is about the geography of Somaiya Hospital. Years back, somewhere in 2015, we published a paper, Profile of Acute Febrile Illnesses in a Teaching Hospital in Central Mumbai. And that was malaria, dengue, etc. But that paper is still being referred outside all over the world, because it comes from a metropolitan city in relation to infectious disease, in relation to ICU profile, and last, of course, important valuable data. So in identical manner, the diabetes data generated, Dr. Mayur, from a clinic is extremely important, because Somaiya has got a typical patient drainage and population. Because when we do clinical trials, we say that the data must be inclusive. And here you have a medical college hospital, and you also have a super specialty hospital. So you will get a diverse type of inclusive data, which matters most in the profile of diabetes in India. And you are aware Indians differ so many ways as far as the diabetes is concerned, that all that apple obesity and this and that, much different. So your data is going to be extremely important. I wish that it results into meaningful publications, and data from Somaiya Hospital finds a place in the global diabetes scientific literature. These are my hopes and best wishes to all of you. Once again, thank you for inviting me.
I would request Dr. Mayur Mewara sir to please felicitate Yolika sir.
As far as COVID is concerned, if what
I would now like to invite a second special guest, Dr. Sadanand Shetty, sir. Sir is one such distinguished personality whose career reflects excellence and a lifelong dedication to advancing medical sciences. I would request sir to say a few words.
On this platform, since 91, I might have talked in so many talks. In fact, I had the privilege of taking part in the opening of our institution, 7th June 91. Now, of course, there's not much of time to talk about today's topic. Diabesity is not a new word. Only thing is now we are giving more importance because we have got many medicines to reduce the obesity. In simple word, I would say that we have a central obesity as compared to the Western population. We have a genetic predisposition to central obesity. So essentially our illness is adiposity and adiposopathy. So what we should do, we can't alter the genetic predisposition, but we can easily control by two simple things. One, by regular physical exercise, and second, by maintaining strict diet. Just to give example, during one of our discussion today, every time all the discussions were saying genetics, we can't alter. My friend from USA today, texted, my HDL was 30. He is an Indian, he settled in America. But after exercise and by regular, diet and all, now HDL is increased to 60. So we shouldn't be carried away that genetically we can't alter, we can easily alter. With this, I would like to thank Mayur and Department of Medicine, which I was the part right from 91. Thank you very much, Mayur.
I would request Dr. Vishal Gupta, sir, to please felicitate Sadanand Shetty, sir. Our third special guest for today, Dr. Girish Radhajaksha, sir, needs no introduction, yet it is my privilege to introduce sir. Sir is a rare combination of sharp clinical insight, academic depth, and has a mentor's heart, a quality that continues to inspire generations of doctors. Please, sir, could you please?
I was not aware that I have to speak. मुझे लगा सिर्फ शाल डालेंगे बस. Okay, we are professors, so we can speak anytime and any subjects. So, good afternoon, everybody, all the dignitaries on the dais, off the dais, my friend Anil. Yes, diabesity is important. We all know the concept of thin, fat Indian. Though we appear slim, some of us are slim, I am not, but some of us are looking very slim, like Niharika, but still we have a lot of fat in our body, and that concept everybody knows. That thin fat Indian. So naturally our body has more fat, and that fat is responsible. So now क्या दौर होता है, हर एक का दौर होता है, अभी obesity का दौर है. So for 1 or 2 decades, I think it will be all fat, and diabesity. So ठीक है. But I feel, I will tell you in my opinion, I am also treating the patient from January 1985. So with my experience, what I feel, the real risk factor, I have seen people who are obese and living 90 years. I have seen people with diabetes living for 85, 90 years. What I feel more important, and it's very difficult to research, all the best minds in the field of diabetes are here. That's why I'm saying this concept. I feel the people who are happy in life, they live long. That is my concept. Now it is very difficult to be happy in life because we compare with others. भला उसकी कमीज मेरी कमीज से सफ़ेद कैसे, and we get angry. And Anil knows during our college days, for 1 mark, वो मेरे आगे गया, वो मेरे आगे गया, and we used to call such people, they have Jalandhar Express, Jalandhar. So they used to sit in Jalandhar Express. उसको मेरे से ज़्यादा क्यों मिल रहा है? See, everybody has his own share, of good and bad things. but we see only good things in others and मुझे नहीं मिला करके जलेंगे. So I think those who are really nice people, true gentlemen, who don't compare with others and who live life on their own terms, happily, they live longer. That is my experience. So I feel, but there is no research, there is no study by which you can decide who is really happy and who is just showing that he is happy in life. But if you can find out some tool to find out who is really happy, contented, samadhani in life, I am sure you find that they live till 90 easily without any big problem. So with this, I think you all are future consultants, future doctors. You do this study and publish it. Like what sir said, sir used to tell us publish or perish. I remember his terms, publish or perish. So I was not publishing till sir came there. After that, I have got almost 75, 80 papers. So that is only because of Dr. Yevlekar sir who told us publish or perish. नहीं तो professor post नहीं मिलेगी. And that's why we started publishing. Okay, so thank you very much. I must give credit to Niharika and Mayur for bringing me here. Thank you so much.
Thank you, sir. I would now request Dr. Niharika Gill ma'am to please felicitate Dr. Girish Rajadhyaksha sir. I would now like to invite our fourth special guest. We are extremely fortunate to have Dr. Anil Pachnikar sir with us today. Sir is changing lives one patient at a time. So please could you say a few words?
Hello, yeah, I'm audible. Yeah, good afternoon, friends. Respected dignitaries on the dais, our Dr. Vijay Panikar sir, Dr. Yevlekar sir, Dr. Sadanan Shetty sahib, Dr. Minal, Dr. Niharika Gill madam, Bobde madam, and my best buddies, Dr. Girish Rajadhyaksha. First of all, I really appreciate such kind of things over here, that organizing Diabesity, starting with the obesity and treating the diabetes and the other comorbidities. Here I would like to give a special thanks to the Dr. Mayur Mewada sir, the way he has organized everything so smoothly and with the dedication and hard work. One of the best intensivists I have seen in him. I am a family physician from the last 40 years practicing in Dharavi, and I have referred my very complicated cases to the Dr. Mayur Mewada sir, and the way he has taken them out from the ICU at ease without any expressing tension or depressions and all. So I really appreciate you, sir, for your clinical acumen. At the end of the day, they are the students of Dr. M.E. Yevlekar, sir, Dr. Girish Rajadhyaksha and Mayur Mewada, sir. So they have to excel in the life, nothing so big things and all. Dr. Vijay Panikar, sir, as you all know, the doyen of the medical fraternity. Dr. Sadanan Shetty, very cool, calm personality from our Sion Hospital. We always appreciate you, adore you, try to learn from so many things from you and all. Friends, this obesity, when I'm a family physician, I like to always, counsel my patients, because treatment part I refer to the Panikar, Yevlekar sir and Sadanan Shetty sir and all. I don't indulge in much that. But I always say that just if friends, any patients having stress and strain, let them advise them that they should have a good sleep, 7 to 8 hours sleep. They should do the exercise at least 1 hour per day, have limited diet, and the thing is that stress, strain, they try to avoid as much possible, drink lot of water, good food, limited food, good sleeps, avoid stress and strain. I think you will be able to win over most of the diseases and all. So thank you very much. Have a nice time. Thanks a lot.
I would request Dr. Mayur Mewada sir to please felicitate, sir.
He is a dear friend of mine.
I would request Mayur Mewara sir to please felicitate Dr. Niharika Gill ma'am. I request all the dignitaries to come forward for lamp lighting ceremony. I would request all the dignitaries to please come on the stage for virtual inauguration of the Diabetes and Obesity OPD.
Namaste. India faces a growing health challenge with diabetes and obesity affecting millions across all ages. Our modern urban lives, sedentary habits, and unhealthy food choices contribute significantly to this rising prevalence. With over 101 million diabetics and 254 million adults affected by obesity, these conditions lead to severe complications. These include heart disease, stroke, kidney failure, vision loss, and even premature mortality, impacting quality of life. But there is hope. Early diagnosis and timely intervention can prevent these complications and save lives. Introducing the new Diabetes and Obesity OPD at KJ Somaiya Medical College and Hospital. We offer expert consultations, lifestyle guidance, and comprehensive long-term management plans. Our dedicated outpatient department is available every Monday from 2 p.m. to 4 p.m. at OPD number 20. We are committed to providing advanced diagnostics and a multidisciplinary approach for your health. KJ Somaiya Medical College and Hospital, committed to healthier lives.
We seek your blessings and good wishes for the launch of our Diabetes and Obesity. That will be every Monday 2 to 4 p.m. at OPD 20. Please, Dr. Niharika Gill madam and Dr. Vijay Panikar sir, we would like to seek your blessings for our OPD. Thank you so much, all the dignitaries, for gracing the dais. I would now request Dr. Mayur Mewara sir to please felicitate Dr. Pazare sir. Sir is the head of unit at KJ Somaiya Medical College, and sir has been ex-dean of KEM Hospital. I would now request Dr. Mayur Mewara sir to please felicitate Vishal Gupta sir. Dr. Vishal Gupta sir is the head of unit at KJ Somaiya Medical College. And sir is a part of the scientific committee for today's CME. I would request Dr. Mayur Mewara sir to please felicitate Dr. Nikhil Kulkarni sir. Sir is the consultant senior diabetologist at KJ Somaiya Hospital and at Raheja Hospital. We also wanted to felicitate Dr. Kiran Borude sir, who is the MD, Dr. Menu Ramakrishnan ma'am, who is the MS, and Mrs. Taral Taruni ma'am, who is the COO of KJ Somaiya Hospital. Moving forward to our scientific sessions, I request Dr. Niharika Gill ma'am, Dr. Vishal Gupta sir, and Dr. Nikhil Kulkarni sir to moderate the scientific sessions for today. Moving forward to first talk for today, I would like to request Dr. Vijay Panikar sir to enlighten us regarding the treatment of obesity.
Good afternoon, ladies and gentlemen. We have seen a fantastic inauguration. First time button daba ke, it was a virtual inauguration of a obesity diabetes center. Very well done. Obesity, like I said, everybody used to take it very lightly. You see somebody who was obese, अरे वो जाड़िया जा रहा है, या जाड़ी जा रही है, ये देख खा पी के मस्त है. That was the kind of comments that used to come. But actually, it is not his or her fault. Basically, obesity is a chronic, relapsing, treatable disease. It's not a failure of willpower. कि मैं control नहीं कर सकता है खाना. No, that is not the reason. It's a biological disease and it has been classified as a disease. And the current update, 2026, we are just 20 days into 2026. It is considered as a chronic, relapsing, neurometabolic disease. It's not a cosmetic disease. I mean, just look at the BMI, oh, he's fat, he's obese. No. It is a metabolic disease and it requires long-term multimodal therapy. If you look at all the different associations across the world, you look at the Endocrine Society of India right in the middle. It says obesity is a chronic, relapsing, progressive disease defined by excessive adiposity that may impair health. So that is the definition. So it is now being considered as a disease across the board. And how do you classify? For Indians, a BMI over 23 is considered overweight, because we are what is known as the thin fat Indians. Though we are thin, we have more fat compared to the Caucasians. And that more fat is a visceral fat right on the abdomen. So Indian obese are basically central obesity. You look at a Caucasian who is fat, he's fat all over. But you look at Indian, he's fat on his belly. And that is the insulin resistance factor that comes. So for Indians, overweight is 23, obesity is 25 BMI. And the basic treatment goal is to get a 5 to 10% weight loss, which will give you metabolic improvement. So why the obesity treatment has changed? Obesity is prevalent globally, and even in India it has become an epidemic. I go for a morning walk every day, and I see the school, kids waiting for the school bus. 50% of those children waiting for the school bus are obese. Bas kha pi ke gol matol. Yeah. That is the level of obesity. And it's there in India also. And the traditional diet, exercise have failed. 80% failure rate. Nobody really succeeds with diet and exercise. There have been quacks across the board. There are certain institutions, weight reducing thing, they would charge you by the kilo. Kitna kilo kam karne ka hai? 10 kilo na? 3,000 rupees per kilo. And that how the rates used to be fixed. Actually this used to happen. All hoax, nothing used to really work. But now we have an understanding of what the biological set point is. Try and understand that basically patients don't fail diets. The diet fails the basic biology in the patient. Try and understand that. And now here, the body will always defend weight. The moment you try to reduce weight, your weight comes down below a certain level, that's a set point. Somebody has a set point, say, at 90 kilos. You do diet, exercise, do the gym, dietitian, trainer, and you bring down to 85. The moment it comes down to 85, your set point was 90. You're bringing it down to 85 means you're, pulling that spring down, either, and you're trying to hold it there at 85. But the moment you relax, tup, that spring goes, and next, you are 95. So that was the set point. And why does that set point remain? Because the moment it goes below that set point, there is an increase in hunger, which is mediated by ghrelin and leptin sensitivity. There is a reflex metabolic slowing. So there is a decreased energy expenditure, and there is an increased fat storage efficiency. So more fat gets stored. And the weight, when it goes above the set point, it was 90, he has eaten, bahut khaya, 95 ho gaya. The appetite signals go down, but they're blunted in obesity. They enjoy the food. Kha pi ke chalega, no problem. Energy expenditure modestly reduced. So basically, defense of the weight from going down is more important than the regaining the weight. So what is the basic challenge? Whenever there is a weight loss, there is a decreased energy expenditure, increased hunger, decreased satiety, and the weight comes back. So it's hard to treat. Lifestyle alone is not going to work, because the disease is not only lifestyle. There is something beyond that. Like chronic nutrition, there is a leptin resistance. The set point keeps shifting up. You're 90, then it shifts to 95, 100, and it goes on and on. And after weight loss, the moment you have weight loss, the body behaves as if it is starving. My God, bhooki hu main. मैं खाया नहीं कुछ एक दिन. And that psychological and thing, that's what your body is also looking at. And that is what leads to the plateau. You may lose 5 kilos, and then you're working your everything off, still it doesn't move, because it plateaus. There is a powerful hunger after dieting and long-term weight gain. So basically the main question is, can you can the set point be lowered? खेल पूरा set point का है. If you can reduce the set point, yes, it can be reduced, but it requires sustained biological intervention. And anti-obesity pharmacotherapy which is currently available, that is a GLP-1 analog and the GIP, GLP-1 agonist tirzepatide, are pharmacological intervention to reset the set point. Bariatric surgery is a very potent means to reset that set point. Long-term lifestyle changes can support, but they are not sufficient alone. So the basic thing is to reset that set point. So the clinical takeaway is obesity is not a failure of willpower. अरे वो बेचारा बहुत try करता है, कुछ हलता ही नहीं है. And I have tried it myself, not a issue. Effective treatment works by resetting or defending a lower weight set point, not by fighting biology. So the core concepts is hypothalamic appetite pathways, gut hormones, the GLP-1, GIP, the PYY, adipose. Weight regain is biological. Come. So why obesity matters more than ever? Because obesity is a cause of insulin resistance. And that insulin resistance is the main driver for onset of type 2 diabetes, cardiovascular disease, atherosclerotic vascular disease, NAFLD or MSLD, chronic kidney disease, cancer, hypertension, PCOS, and you name the thing. Everything is driven by insulin resistance, and at the core of that is obesity. And that obesity mainly a visceral obesity. And the Indian phenotype has a lower BMI but a higher visceral fat. So that is why Indians are very, at high risk for developing diabetes, for developing cardiovascular disease and stroke. So weight loss of 5 to 15% can cause disease modification. We are not talking about a cosmetic effect, कि 15 kilo कम हो गया, चिकना दिख रहा है, no. It is a disease modifying effect. So we are no longer just treating weight. We are treating the patient, of course to reduce weight, but as a corollary to that weight reduction, we are reducing his risk for long-term cardiovascular and other events. And you want to reduce the progression and improve the prognosis of his whole life actually. So what are the new treatment goals? The old goal was only BMI. Reduce the BMI. There was no other concept. But now we are talking of fat distribution and metabolic health. We want the visceral fat to be redistributed. And pioglitazone is a wonderful molecule which will reduce the visceral fat and increase the subcutaneous fat. So everywhere now they are now looking at using a combination of GLP-1 with pioglitazone. GLP-1 itself, when you cause weight loss, reduces visceral fat. The waist circumference comes down significantly. I will show you the later on. Earlier the goal was the short-term loss, weight kam karne ka hai, bas. And it was cosmetic. And even now, I see patients, in fact my associate recently was telling me that a whole family is getting treated with GLP-1 analog because the daughter is going to get married in 6 months. So the daughter is on it, the mother is on it, the father is on it, the brother is on it. They all want to reduce weight and look smart for the wedding photograph. This is ground reality. And it works. So evaluation of a patient with obesity, beyond BMI, look at the waist circumference, very important. Complication-centric, see if he has got diabetes, hypertension, dyslipidemia, MSOD, whatever, and secondary. So basically you want to treat obesity to prevent and treat the complications. Lifestyle still has a foundation. Low caloric diet, but remember one thing, whenever there is a weight loss, suppose somebody loses 10 kilos of weight, he is going to lose 7 kilos of fat and 3 kilos of muscle. That lean muscle loss is to be prevented. That is sarcopenia. And with age, sarcopenic obesity is quite rampant. You have the elderly who are obese, but their muscles are all gone. And this is because of a low protein diet. Our vegetarian brothers have hardly any protein in their diet. They need high protein. So here, when you talk of dieting, it should be a high protein diet, 1 to 1.5 grams per kilogram. Resistance exercise and aerobic exercise will contribute to muscle building, sleep and stress management. So when would you add a pharmacotherapy? When all your diet, exercise, everything doesn't work, then you can think of it. If the BMI is more than 27 with comorbidities, if he's diabetic, if he's got a cardiovascular disease, yes. BMI more than 30 can be an indication to treat with these drugs. Delay worsens the metabolic change, so treat early. These are a list of all the drugs that have been used to treat obesity. But if you look, the best weight loss is right at the end of the thing, 20% or 21%, 22% with tirzepatide, that is your Mounjaro. The semaglutide is about 14%. If you look at the GLP-1 agonist, the weight loss, good weight loss, it also has an effect on fatty liver, on NASH. It causes resolution of it, even reduces the fibrosis. In fact, semaglutide has been approved by the US FDA as a treatment for MAFLD. There are very few drugs which are approved for the treatment of NASH and MAFLD. One is resmetirom and the other is semaglutide. There are no other drugs which are approved by US FDA as of now. Tirzepatide is your Mounjaro dual. It's a GLP-1 and GIP. Good 20% weight reduction with a 15 milligram dose, 22% with a 15 milligram dose. The BMI can come down from 38 to start with, can reduce to 30. It's like doing a mini bariatric surgery. It's a pharmacological bariatric surgery. So even the tirzepatide is good for MASH and liver fibrosis, liver enzymes reduce. This is another drug which is in the pipeline. It's a kid on the block waiting to just come and might come next year. This is retatrutide. We have seen GLP-1, semaglutide is just a GLP-1 agonist. Tirzepatide is a dual agonist, GLP-1 and GIP. Retatrutide is a triple agonist, GLP-1, GIP and glucagon. And there the efficacy is much more. If you look at the fatty liver, in 24 weeks, 80% of the people, the liver is cleared out. And at 48 weeks, 90% of fatty liver clears out completely. Excellent results. These are in the pipeline, anti-obesity drugs. You have oral semaglutide, you have orforglipron, which causes about 12% weight loss. This is the first non-peptide GLP-1 receptor agonist. Let me repeat, non-peptide. All the other GLP-1s are peptides. They can't be taken orally. So semaglutide orally has to have a real lot of drama to make it absorb. This is a non-peptide GLP-1 agonist. Very good results, likely to come in next year. Retatrutide is also likely to come next year. In fact, phase 3 studies are going on. So if you look at the old and new, orlistat is a simple drug which blocks the lipase in the intestine and thereby prevents the digestion and absorption of fat and can cause about 3 to 5% weight loss. Liraglutide 8 to 10% weight loss, but in practice it's hardly anything. I'm not really happy with it. Semaglutide 2.4 milligrams can cause 15% weight loss, tirzepatide 20 to 22%. I'll go quickly. Now weight reduction with tirzepatide, that is the SURMOUNT-1 study, with 5 milligrams 16% weight loss and with 15 milligrams you're 22.5% weight loss. When you compare this with semaglutide gives you a 15.4% weight loss at 72 weeks and this gives you almost 22% weight loss. And if you look at this, almost 1/3 of the patients on Mounjaro would have lost 25% of their weight. Now, talking about the waist circumference, there is a fantastic, if you look at the black one is with semaglutide, 14.7 centimeters, and this is 20 centimeters. That means almost 7 inches of the waist. So that kind of a waist reduction, that means visceral fat going down. And when you talk of glycemic control, between these are the only two molecules currently available to us. So GLP-1, good HbA1c reduction 1 to 1.5, but tirzepatide is much better at 2 to 2.5. GLP-1 weight loss 5 to 10%, this is 15 to 22%. Cardiovascular, the cardiovascular outcome trials are only there with semaglutide. That is your MACE. It is proven MACE, cardiovascular death, MI, stroke, reduced BP, atherosclerotic lipids, and tirzepatide, the SURPASS CVOT trial has come which showed a 16% reduction, no harm, but it's a good drug. They both match actually, but when you look at the data, currently available, there is more data for semaglutide than for tirzepatide for cardiovascular benefit. Renal protection, again, GLP-1, there was a FLOW study which came, which showed it can reduce the albuminuria, so it is renoprotective. Tirzepatide also shows reduction in albuminuria, but there are no specified trial done to really show it. Metabolic and hepatic benefits, both of them are really good for it. It can clear the fatty liver and even reduce the SGOT-PT and things like that. So to summarize, which would you prefer? When you talk of weight loss, you would prefer tirzepatide over sema. When you talk of a HbA1c reduction, tirzepatide over sema. You want to preserve lean mass, tirzepatide over sema. Basically, if you ask me, there is nothing to choose. Both are good. You only see which is cost effective. And if you look at the last line there, the 2.4 milligram and 15, which is the top dose of these drugs, cost 16,000 rupees and 25,000 rupees. And you have to see that pocket of your patient. That is most important. And I will tell you 99.99% of the patients of Indians cannot afford these drugs today. But good news is that semaglutide is going off patent on 20th of March 2026. The Wegovy and the Ozempic are going off patent. And we have at least 20 Indian companies ready with it to launch in the market on 21st of March. And I am told the price will be very, very competitive. So when that price becomes competitive and you have Mounjaro at 25,000, and if you can get semaglutide at say 3,000 or 4,000 rupees, I would prefer semaglutide to my patient. Though Mounjaro might have a little extra weight loss, but I don't mind that. Paisa to kam bachega. So the clinical take-home best choice for type 2 diabetes is GLP-1 who have got cardiovascular disease, CKD. This is the 2026 ADA guideline for standards of care in weight and obesity. 2026. And if you look at it, all across, whether it is pre-diabetes, whether it is type 2 diabetes, hypertension, ASCVD, heart failure with preserved ejection fraction, MASH, obstructive sleep apnea, osteoarthritis, everywhere you see it is either a semaglutide or a tirzepatide is the first drug of choice. That is the way these molecules have come in, because that weight reduction gives a superb improvement to all these things. A person known to me, I would say my relative, she was quite obese and she had obstructive sleep apnea. She used to have CPAP machine. She had osteoarthritis, could not move. She is 65, 70. With this drug, she's lost 15 kilos weight. On this New Year, I saw her dancing. Actually, I was surprised. She is off the CPAP machine. So that is the kind of improvement you can expect in these patients. The common concerns are nausea, which is transient dose related, gallbladder stones, any weight loss program, whether it is diet, exercise, Monjaro, bariatric surgery, any acute weight loss program can increase the chances of gallstone formation or increase the extent of the current gallstones which are there. Thyroid cancer, no human evidence, but let me tell you, I have seen at least 4 cases of thyroid cancer. 4 cases. In fact, this morning, I saw one patient who had a calcitonin of about 50. Because in my clinic, we routinely ask for amylase, lipase and calcitonin. So, we'll have to investigate him whether he has got it. It is generally seen if the patient has got a familial multiple endocrine neoplasia syndrome. But we don't know kiska hai, kya hai. So, to be on the safe side, otherwise medico-legally tomorrow they can sue you कि ये तुम दिया और मेरे को medullary carcinoma thyroid हो गया. It's just a routine to be done. I won't. The key takeaway would be that obesity is a biological disease. It is a disease which needs lifelong treatment. Lifestyle, lifestyle is necessary but not enough. Early pharmacotherapy will prevent complication and give you good outcomes. GLP-1 and GIP therapies are disease modifying. Treat obesity like diabetes, early, sustained and individualized. It should be long term. If you don't treat diabetes or obesity early, we will keep treating its complications forever. The moral of the story is, shuru mein lag jao, and with the cost coming down, I think it is going to be a big boon. That cost was the single factor holding me back from giving it to all my patients. But let's see. Thank you very much, ladies and gentlemen.
Thank you, sir, for your very lucid presentation. I just have one question to you. Since you have been using pioglitazone for a long time, do you think combining pioglitazone along with semaglutide or something like this will help in the Indian phenotype of diabetes?
Absolutely. See, we are an insulin-resistant population. And pioglitazone, there is no better molecule than pioglitazone to treat insulin resistance. Semaglutide does it by virtue of weight loss. And if you look at all the guidelines, you look at fatty liver, whether it is the ACE guideline, ADA guideline, ESD guideline, it says GLP-1 with pioglitazone. GLP-1 with pioglitazone and SGLT2. If you look at Ralph DiFranzo's study on prevention of type 2 diabetes, the thing is weight reduction with GLP-1, then you use a metformin, pio or acarbose.
True.
And the best combination for total prevention of diabetes is a GLP-1 pioglitazone with metformin. Zero occurrence of type 2 diabetes. So it is a wonderful combination. The slight weight gain with pio which is there is neutralized with this. Absolutely no problem.
Thank you very much, sir. Any questions from the audience? Please.
The question is, how long should we take semaglutide or tirzepatide? Ideally, it is to be taken lifelong.
Okay.
Because this is a disease which is going to remain with you for life. And there have been studies done of stopping the drug. After 38 weeks, they have stopped the drug and they have seen what happens to it later. What they found is that they followed up for 1 year. 25% continued to maintain the weight loss that they had. 46%, and all of them had reduced about 15% weight. 46%, they maintained about 10% weight loss, not the 15%. But 25% regained their weight and much more. So it's a disease. It's like saying you've got blood pressure or diabetes. Jindagi bhar treat karna hai.
But there they are developing suicidal tendencies. That is what the article
See, there was a video on this, that these drugs increase suicidal tendencies. There have been reports, but there is no authenticated data on it at all. Let me tell you that. But here, if somebody has a psychiatric problem, you beware, don't put them on these drugs. But otherwise, there is absolutely no problem. There is no scientific data on the level of suicidal tendencies. एक मिनट, if suicidal tendency नहीं तो murderous tendency भी आएगा. कुछ नहीं यार. Yeah. How to prevent sarcopenia in a patient? Yes. See, sarcopenia, especially in the elderly, is a very important factor to be seen. So the prevention of sarcopenia is, one is a high protein diet, 1 to 1.2 kilograms per kilogram body weight diet, regular exercise. If they are unable to really walk and do exercise, they can have a fitness thing, person coming, trainer coming to them, give them resistance exercise. That is the way to, simple thing, sitting in a chair and getting up and standing. Getting up and standing can be done at home. Push up on the wall. But that should be done. Yeah.
Happy New Year.
Oh, same to you. Happy and a healthy New Year.
Definitely. So one comment and one simple question. So India is number 1 in diabetes, number 1 in cancer, number 2 in obesity, number 3 in MSLD, and number 99 in the global preparedness to tackle obesity. This was the comment. Now the question is, do you consider GLP-1s or GLP-1 GIP as the new anti-aging or longevity molecules?
See, it could be, I would not say anti-aging.
To age gracefully. Aging to hona hi hai, marna to hai hi. But, quality of life, health, happiness.
Jara chikna dikhega thoda din. But
I'm talking about cardiometabolic disease.
Basically, these are disease-modifying drugs.
Right.
Which can definitely improve the longevity of the patient. Because if you treat early, you prevent him from becoming diabetes, you prevent his cardiovascular problems, he will live longer, yaar. Why not?
Better quality of life.
Yes, yes.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you for the interesting lecture, sir. It was very thought-provoking, and I hope you all have taken notes and will also forward them. Moving on to our next lecture, I would like to request Dr. Anurag Leela, sir, to shed some light on secondary causes of diabetes, mellitus, and obesity. Sir is DM endocrinologist and is professor of endocrinology at St. G.S. Medical College and KM Hospital. Please, sir.
Thank you everyone for having me here. So I'll be talking on secondary causes of diabetes. So obesity is mother of all illness. We all agree to it. But sometimes there are stepmothers which should be recognized. So there are certain secondary causes which you should recognize before labeling obesity as an essential obesity. So that's what simple messages I'll give through few of the cases in the coming 15 minutes. So when do I suspect that there may be an underlying endocrine cause for my obesity or diabetes? And how do we screen them and how do we look for it? So we have pituitary, thyroid, parathyroids, adrenal, pancreas, gonads. These are the few organs which are directly linked to endocrine hormone secretions. and we will go through the cases from each scenario and take it further. So pituitary causes, we have Cushing's disease. So this lady was labeled as diabetic, and it was difficult to control on OHAs and insulin. She is hypertensive as well. So when she comes to our clinic, she has certain mooning of face, which sets her apart from other diabetic patients in our OPD. Based on that, we did a simple screening test of ODS cortisol. So you give 2 tablets of dexamethasone in the night, and next morning you do a cortisol test. So normally my cortisol will be undetectable or very low. If the cortisol is detectable even after dexamethasone tablet, that means body is making endogenously that cortisol, which is autonomously produced. And this small tiny lesion in the pituitary gland, which is a microadenoma, is causing all the conditions of diabetes, obesity. And if you miss it, you may put her on semaglutide and liraglutide for ages, but you may miss the primary diagnosis in such a scenario. So the message is, clinically, if you have, like when you have insulin resistance, you are not frail. Cortisol is a catabolic hormone. So skin, muscle, and bone weakness in a diabetic patient or an obese person should suspect there may be a cortisol excess. So in this case, treating her with transphenyl surgery, her sugars came down from 3 to 1, insulin was stopped. Then there was a recurrence, she underwent radiation therapy, again the disease has recurred, but again after the radiation effect started, she is doing fine from her aspects. So cortisol works on both insulin secretion and insulin resistance pathways. So as I said, the catabolic manifestation on the skin. So I remember my MD days when we had one patient who was actually Cushing's, and when we clinically examined per abdomen, when we see those stria which were depressed, and then we made a diagnosis of Cushing. I still remember it was a eureka moment that we have made a diagnosis of Cushing in a busy diabetic OPD during the MD days. So skin, which are catabolic stria, which are depressed stria, if you have muscle weakness and if you have bone weakness. Now this patient was admitted with hypertensive crisis, he has edema, he has plethora, he has skin changes, and when you treat him with his Cushing's, all of these things resolves. So Cushing can come in varied spectrum. Not everyone will be a florid case with all these conditions. But the good point is if we do the simple ODS test, you will pick most of them. So if you suspect Cushing's, please do a ODS cortisol. If it is suppressed, you have ruled out Cushing's in such a scenario. In this study, we have enrolled 1,000 type 2 diabetic patients and found that this test do very good in our OPD. So we should clinically suspect it. More often than endogenous, we have exogenous Cushing's, which you have encountered where patients are taking medications because of the weight and the osteoarthritis. Many prescriptions of steroids goes unnoticed, and that need to be checked as well. In that case, we do a basal cortisol to tell that they are taking exogenous steroids. It's usually a mixture of multiple steroids which give them relief and euphoria. Second condition is acromegaly. So I remember him from my OPD days. I was reading chapter on acromegaly. Next morning I go to the OPD. The only acromegaly is in my mind, so I picked him. He was following in my OPD, so I was very happy. My professors have missed it and I have picked it up. So, but these are very subtle cases. So, and he's a taxi driver. Whenever I need a taxi, I just call him, he comes back because I had diagnosed him with this condition of macroadenoma. He underwent surgery. He got remission of the diabetes from his condition. So this was a very subtle case of acromegaly. Many cases it are obvious. So this is how he has followed. So again, growth hormone, all hormones are against insulin basically. The thyroid, cortisol, all are anti. They have lobbied against insulin. So they work against insulin. They causes decrease in insulin secretion. They create an environment where the insulin cannot work, or they decrease the insulin secretion. So these are various manifestations of acral enlargement. The third picture is a giant. You can see the mother. The hands acral enlargement, cutis vertis gyrata. So these are clinical signs which you can look into where the growth hormone excess can be there. Usually they are big tumors, macroadenomas, and can be picked up. So you have varied spectrum of acromegaly and diabetes. GH and prolactins are brothers, growth hormone and prolactin. Even prolactin secretion, so prolactin is a metabolic hormone. Again, it causes metabolic syndrome. So again, if you have a tumor because of prolactinoma, again the diabetes may be there, and treating prolactinomas, you don't need surgery to treat such big tumors. Simple drug like cabergoline they melt like lymphomas when you treat them with cabergoline. So these are one of the tumors where you don't need to send them to a neurosurgeon, and with the cabergoline they melt away. So prolactin causes infertility, erectile dysfunction. So in a diabetic patient, when you are following, the most common cause of increased prolactin is domperidone or levosulfuride use. After ruling that out, if someone has a high prolactin, decreased libido, decreased testosterone, it can be a micro or a macroprolactinoma, which is easily treatable with cabergoline. And these high prolactin can cause metabolic syndrome, as growth hormone and prolactin works in a similar line. Going to the hyperthyroidism, this case young girl who had a syndrome, autoimmune polyendocrine syndrome, where she got Graves' disease and her sugars got uncontrolled very much, and they do have autoimmune diabetes, but the sugars started fluctuating once she got into hyperthyroidism. Again, the thyroid hormone control caused the control of the sugars as well, started getting into hypoglycemia once the thyroid was controlled, and again the doses were adjusted. So again, thyroxine, as I said, most hormones works against insulin. Growth hormone, prolactin, cortisol, thyroid, any excess of these hormones will cause diabetes, obesity, and weight loss, weight gain. So this is one condition where hyperthyroidism, even in your routine OPD, when a diabetic patient comes and still they get into Graves' disease or hyperthyroidism, the sugar control goes for a toss for that duration of period. Once you control hyperthyroidism, again the sugars become better in that scenario. So one condition is parathyroid conditions, where we can recognize simply by doing a serum calcium. So parathyroid gland leads to, this is a case of hyperparathyroidism who was on diabetic for some duration. We can recognize it by MIB scan. Now we do a 4D scan to recognize parathyroid glands. And after correction of the parathyroid surgery, the sugars were well maintained. So how do parathyroid causes and hypercalcemia causes? It causes calcific pancreatitis. So there may be a chronic damage of your pancreas. And per se, the chronic calcific pancreatitis is hypercalcemia causes chronic calcific pancreatitis. So it's a secondary cause of damage to the pancreas. Plus hypercalcemia per se causes decreased insulin secretion, and the GLUT expressions can go down, and diabetes can happen. And the parathyroids, which we conventionally were seeing with the fractures and the renal stones, are no more seen. We see asymptomatic hyperparathyroidism very often, especially after the vitamin D supplementation, which has become very common. Now asymptomatic hyperpara, one patient per week we are operating at KEM on a weekly basis for asymptomatic hyperpara. Asymptomatic hyperpara is no more a disease of the Western world. It has reached our part of the world also. So on a routine screening, please look at the calciums, and these calciums may be linked to other metabolic conditions, including diabetes. So calcium and PTH is a good screening test. If you have hypercalcemia, you should suspect this condition, and add-on PTH can be helpful. Coming to the adrenal gland now, pheochromocytoma. So this man has pheochromocytoma, which is the adrenal tumor, which is causing hypertension and diabetes. So sympathetic upregulation happens in pheochromocytoma, which leads to diabetes and hypertension. Hypertension is a primary manifestation, and the plasma-free normetanephrine is the drug of test of choice we do in such a scenario, and a CT scan and a DOTA scan can pick up the tumors. Again, in this patient, when I remember one of the patients of pheochromocytoma in my first year of DM residency, when I discharged, diabetes and hypertension cured. So these are some tumors where conditions where you hardly write such situations where you're no more requiring these drugs for life. Similarly, catecholamine excess, it's a sympathetic drive which is going to cause the sugar rise. Similarly, we have primary aldosteronism, the other hormone which is excess from the adrenal gland. Like this patient, these are small tumors which are in the adrenal gland, where the renin-aldo test is useful to diagnose them. And because of the hypokalemia, the insulin secretion goes down, and they are associated with diabetes. So diabetes, hypertension can be linked with the adrenal causes as well. Last but not the least, in pancreas per se, the insulinoma causes hypoglycemia. If you have a tumor of the pancreas causing insulinemia, they get weight gain and they cause hypoglycemia. You don't get into diabetes because you have insulinoma, but after insulinoma surgery, you get into diabetes. And similarly, if you have glucagonomas, all these GLP-1s which causes weight loss, the GLP-1 causes lot of weight loss, but it produces diabetes. But the other GLP-1s which produces endogenous will not. So this is how these conditions work. Just to summarize, in the pituitary we have seen if you have catabolic manifestation in the skin, bone, muscle, plethora, please look for Cushing syndrome, and a ODS cortisol is a simple test. In case you are suspecting acromegaly, please do a serum IGF-1, which is a screening test. Growth hormone should not be done there in that regard. Prolactinomas, if you have a patient complaining of erectile dysfunction, infertility, a serum prolactin high can give us a clue towards it in a diabetic patient. Serum, if the sudden change in the sugars have happened, hyperthyroidism may be a cause. Hyperparathyroidism in case of calcific pancreatitis or other manifestations where the routine checkup have a high calcium, we should look for it. If we have hypertension and diabetes, we should rule out pheochromocytoma is uncommon, but cons nowadays is very common. So DRC and aldosterone for every hypertensive have become a rule. But pheo you may not be looking into everyone, but a very young hypertensive with an adrenal mass, please do plasma metanephrines. Primary aldosteronism, like any hypertensive, now we screen for renin, like we screen for renin and aldo in every hypertensive, at least at the onset of a hypertension these days. And rare conditions of pancreas per se can cause secondary diabetes, like somatostatinomas. Those are very, very rare case reports. So this is to summarize the whole scenario where we should not be labeling everyone as essential. Obesity is mother of all illness, but please look at the stepmothers. Thank you.
Excellent talk. The floor is open for any questions.
Or statins for that matter. These three classes of drugs can cause diabetes: thiazide, beta blocker, statins.
Sir, yes, sugars may go from 100 to 102.
102. That's all.
अश्वत्थामा मर गया सर.
Okay.
वो सच भी है और झूठ भी है.
Okay. So how seriously should we take it?
नहीं, और उससे ज़्यादा नहीं है सर.
Thank you.
So you said vitamin D3 causes high calcium and then...
So no, so it's a mass. So what happened in the Western world, they have fortified their food with vitamin D 20 years back, which was not done in India. Like we have iodinization of salt. So that program was not there in India because it was considered as a sunshine country, correct? So because of that fortification of vitamin D, in the Western world, they started getting asymptomatic hyperparathyroidism more often. So it's an offshoot or a side effect of the mass vitamin D fortification of the whole society. Now what has happened in India after 2007, vitamin D became a new fad and anyone and everyone have received vitamin D. The effect of that, it was not through fortification, but it was through a very common prescription, which every prescription has vitamin D, and everyone at some time have received vitamin D in some form. So that is why we have started seeing the offshoot of it, which is asymptomatic hyperpara. Now the arrow is out, we cannot take it back. Now we have to accept the asymptomatic hyperpara and manage and treat it.
Thank you.
Hypovitaminosis D.
So hypervitaminosis D, yeah. So if you define hypervitaminosis D by a cutoff of 30, which will be there in 90% of us, so it becomes an association for anything and everything in life. Hypo, sir. Yeah. So because you have defined by 30, which all of us are deficient, so it becomes an association or a causation. You cannot dissociate. You associate vitamin D deficiency with anything, it will be true. 30.
Thank you very much. Thanks for your enlightening talk.
Sorry, sir?
Can we move to the next session,
So
please?
stress is something non-modifiable, non-measurable factor. उसको माप भी नहीं सकते सर, माप ही नहीं सकते तो चेंज कैसे कर सकते? So aging, stress, genetics and weight. These are the 4 factors which will cause metabolic factors. You cannot reverse aging, you have to age. Genetics, you cannot change your parents, neither you don't want to. Okay, genetics, otherwise you should pray that I should be born in Caucasia next time, not in Asia. Correct, sir? Weight is something modifiable but difficult, and stress is something which is not measurable even.
Thank you so much, Dr. Anurag. Exciting lecture as always, and an eye-opener. Thank you so much for the beautiful lecture.
Thank you. I would request Dr. Vishal Gupta sir to please felicitate Dr. Anurag Leela sir. Moving on to our next lecture for today. We all have heard of this saying, you are what you eat. And so let's hear how diet plays a crucial role in the management of diabetes mellitus and obesity. Please welcome Dr. Sanjeet Sasidharan sir.
Good afternoon, everyone. I just come a little bit early because the speaker after me is probably exercising, not losing weight. Well, my name is Dr. Sanjit, and there has been episodes where you have 2 patients, 2 clients who've been obese. You give them equally different diets. I mean, same diets. You give them the same diets, but one loses and one struggles to lose. And this is something that we've been seeing for a very long time. You know, there is situations where we do not know what's happening to this. That's because of the fact that we've been feeding our patients really to their weight and not feeding them to their metabolism. That's the main important thing. If you feed them to their metabolism, there's a very high certainty that these patients will actually lose weight. And that's precisely why I'm here, to understand, to make you understand as to how I would do this to actually improve precision nutrition when it comes to obesity and diabetes. Well, an average patient that walks into your clinic, you would probably ask them to do a body weight, a body mass index. You would guess the calories that person would require, and you'd put them on generic macros. This is what you'd probably do in these cases. But remember this, the obesity individuals are very, very different. They are not like this. One size doesn't fit all, you're right on that. Well, they have a very different metabolic profile with a very different resting metabolic rate. This resting metabolic rate will actually depend on fat oxidation, will actually determine how much is your carbohydrate tolerance. So the RMR is very, very important. The muscle quality of all these obese individuals are very, very different. Some of them are functionally not okay, because of which they are unable to take those glucose as sinks inside the body. So that's another thing that happens with muscle mass. So the quality of muscle actually determines a lot on these obese individuals. The third thing is that the mitochondrial efficiency of all of these obese diabetics are very different from each other, and that's why it all depends on your oxidative phosphorylation or oxidative way that the carbohydrates is utilized. So the mitochondrial efficiency is different. The substrate utilization also is different. One utilizes carbohydrate, the other utilizes fat. So one loses weight while the other doesn't. So there's a substrate utilization issue that occurs in these patients, and there is a very important gut metabolic signaling that occurs in such patients. If you have those particular organisms in the gut, you will kind of get much more leaner than the others. So there are five different things that happens in adults. So how can you give the same diet to 2 different people? It's not possible to do that. Well, and that's why we must understand body composition analysis. I think this is not working well. Do you have another computer? This computer isn't working well. You have another laptop? The one that they showed me? Give me a minute, okay? So, because this isn't paying the slides properly. Can you put this laptop here? That's what they showed me. That was working well. It's got a different program here. It's on Windows 11. Yeah, this is Windows 11. Anyway, so At the end of the day, we should be feeding the metabolism and not really the weight of these particular patients. No, no, no. I need you to change this computer. Computer change करना है. Program बराबर नहीं है. Put this one. Okay. Yeah, it's better now. So I just explained to you why traditional guessing is not as good as if you were to actually use precision nutrition. And when I say precision nutrition, there are 5 important things that come in. One is called as body composition analysis. The other is CPET, cardiopulmonary exercise training, indirect calorimetry, hand grip dynamometry, and gut microbiome. These are the 5 things that will answer the questions that were asked in the audience some time ago. These are the 5 things that probably anyone will do, because we need to feed physiology rather than the weight. That's the most important thing. You need to feed physiology rather than the weight. That's the most important thing. So let's go to what body composition analysis is all about. Well, you would have seen this in your gyms. You know, the BCA machines, the BIA machines that you have, on which you stand up and you get numbers. These are those machines that give us a lot of numbers on it, which includes weight, fat, fat-free mass, lean mass, soft body mass, extracellular water, and it looks like a report that looks like this. This is how the report looks. But remember, this report is, you might consider this to be descriptive. It says this is this particular patient, but no, this is prescriptive. With this is what you do to actually prescribe your macros. You use this to actually prescribe and not just describe an individual. You might think he's got so much fat, but you can utilize each of these to actually prescribe. Now, how do you do that? Well, there's a lot of things that you look at over here. Let's look at skeletal muscle mass. So if the skeletal muscle mass is the glucose sink, if you don't have skeletal muscle mass, your glucose isn't going to be utilized. And if there is no glucose that is going to be utilized, it's going to be converted to de novo lipogenesis. Fat will not be lost. Very importantly, skeletal muscle mass actually dictates where you actually go. The second thing that you have over here is visceral fat. Visceral fat is something that remains around your organs. They are adipose tissues that remains. It's not just an internal storage, it's a marker of inflammation. It is something that drives insulin resistance. So if you have a very high visceral fat analysis marker, then probably you need to time the carbohydrates in such a way that you will probably utilize that and not really store them back into as inflammatory masses. Well, the other important, very less recognized problem is the extracellular water, total body water. Now this per se determines inflammation and fluid, and it actually tells us how and which carbohydrate we should be giving to these particular individuals. The phase angle, very underreported. It actually tells you metabolic resilience. So these individuals who are dieting, will they do better or not? It gives you that answer too on this. And the last important thing, as Dr. said in the earlier lecture, that sarcopenic obesity is something that can be seen by skeletal muscle index. So a bioelectrical impedance analysis will actually give you a picture as to what this particular person is, and a way to prescribe your diet if you were to actually analyze each of these numbers properly. But it's important to analyze this. Give a monkey a good object, the monkey remains a monkey. So you have to analyze what it is. It's important that we analyze what happens over here. For example, let's take the example of an intervention that we do. You gave a GLP-1 inhibitor to this particular individual to reduce weight, or you gave them a diet and an exercise. And you found that the weight came down. Wow, the weight has come down. Visceral fat, wow, that's come down. But if you find the skeletal muscle mass going down by 2 kilos and phase angle going down, it's very clear that this is not metabolic success, it's actually metabolic failure. It's very important that you follow this up on a longitudinal basis in individuals, because this is what the problems occurs in such individuals. That's why I believe that if you really want to do precision nutrition and diabetes and obesity, you need to understand that if the muscle mass drops by more than 3%, dieting is dangerous. Visceral fat over 130, carbs must be earned, and I'll come to that. The phase angle, if it drops more than 0.3, your weight loss is harming you, and a grip strength falls more than 5%, your nutrition plan is failing. So you cannot trust your weight or your HbA1c on its own. This is very, very important for us to understand. Well, what about this other training called as CPET? Have you heard about CPET training? Any of you all? Anyone in the audience have heard CPET training? Okay, you would have heard a number called as VO2 max. Many of us have them on our watches, VO2 max, which actually gives us heart rate variability and gives us a number called as VO2 max. Well, we can actually use this VO2 max to actually improve the treatment of obesity by to reduce weight. How do you do that? Well, VO2 max machine looks something like this. You know, you wear mask and you cycle on a cycle, and as the time passes, your metabolic profile is shown to us on a graph. We can see it on a graph as to where you are, how you are exchanging oxygen, how you are taking out carbon dioxide. This is what is shown. So we know from where you will go from not having stress to having stress. And the report looks something like this, very busy report. This is what it looks like. This is how the report looks like. But it's very simple to actually read it out. So what you see there, you can actually understand with this what is the maximum carbohydrate tolerance that a person can do. This is something that you can easily find out from your VO2 max. How do you do that? Well, down there you have a number called as VO2. You know, VO2, that's called 27.8. That is the number. On an average, 27.8 is like the average Indian that we are seeing. More than 30 is what is good. More than 50 are very excellent individuals. VO2 means the amount of oxygen that you can utilize per minute. And that's how you live. You live longer if your VO2 max is higher. If you're able to take more oxygen, you're able to live longer. But importantly, it actually gives you something called as maximum carbohydrate tolerance. Now, what is maximum carbohydrate tolerance? This means if your VO2 max is less than 20, and I give this person a high amount of carbohydrate, which each one in this hall probably might be taking 2 idlis, 3 idlis a day, 2 rices, 1 dosa in the afternoon and 1 rice in the night, you are going to exceed 100 grams of carbohydrate. If you're going to exceed 100 grams, and if your VO2 max is less than 20, I am certain that you're writing up that I'm going to become obese and I probably need a GLP-1 in the future. This is very clear. Because if you have a higher VO2 max, that is when your mitochondrial efficiency gets better. That is when oxidation gets better. That is when all of these things turn around. Okay, it's when your mitochondrial efficiency is better that your glucose gets utilized much faster, your oxidation gets faster, and that's how the patient can tolerate carbohydrates. Well, that's the reason that if you have a VO2 max of 25 to 30, you're still little better by taking 150 to 200 grams per day. So this is how you make nutrition precise. It's not just any generic macros you're giving the precise amount of nutrition to this particular individual. Well, this is about carbohydrate tolerance. Okay, what about this? Some individuals just say, can I just fast it out? You know, can I just fast it out is a question that you normally hear with people. You know, I'll just do a fasting, a 36-hour fasting, I'll do a 8-hour fasting, intermittent fasting. But is it safe? That's the big question that they ask you. So how do you know whether it's safe? Well, for that I need to make you understand something about safe fasting. Again, it comes from the CPET training. What comes from here? What you see as a number over there in that graph is called as VT1. That is the first time that the lactate starts moving in your body as you're exercising. If a lactate starts moving, that means you've gone above metabolic stress. So this is VT1. And what you see on top is VO2 max. So this is the number we try to look at. We look at this number, and if it is less than 45%, it's not good to fast. Because if it's less than 45%, it just says that your stress level is so high that you'll produce cortisol and lactate and prevent you from actually losing losing fat. That's the importance of finding VT1 at percentage of VO2 peak, which we can figure out from this particular CPET training. Well, what nutrition? Then the other thing that happens, many of us may be going to the gyms, and when you go to the gyms, you take up a protein shake, or maybe you might take a carbohydrate drink, and I don't know what. So how do you understand what to take? What do you take? Again, the CPET training comes to us. If your heart rate is less than VT1 during your exercise, more than VT1 during your exercise, that is the time you can train fasted. That means your VT1 is pretty okay, your heart rate is below your VT1, you can actually fast quite well, you can eat protein and fats and you will lose weight. If you're between VT1 and VT2, that's a moderate intensity on that graph that I showed you. You need to have small carbohydrate boluses post-workout. And yes, if you're on high intensity training where your VT2 is above, near about your VO2 max, that is the time that you'll probably need carbohydrates mandatorily. That's why you see all of these super elite athletes eating a banana prior or post their maximum exercise that they do. So that's about how you can time your carbohydrates if you were to actually exercise. So use carbohydrate to support intensity and not fuel at rest. So the worst thing that you can do is have a carbohydrate in the night and go to sleep. So use VT1 to protect your insulin, VT2 to protect performance, VO2 peak to cap carbohydrates. Eat carbohydrates only when your physiology demands it, otherwise don't take it. And remember this, carbohydrates are exercise fuel and not everyday food. It's very important for you to understand this. Well, let's go to the other thing, hand grip dynamometer. Very simple device. I mean, every dietitian sitting in this room will probably know what's a hand grip dynamometer. Well, very simple. If your grip is going down, your longevity is going down, this is not something you'd like to do. When that's happening, you need to increase calories by 10 to 15%, continue deficit to increase protein by more than 1.6 gram per kilogram skeletal muscle mass. And if you have to set the protein floor, the protein is insufficient, you need to increase the protein by 0.1 gram per kilogram if by any chance you are having a grip that is going down. So that's the point. You look at the hand grip and decide on how you should possibly mobilize your carbohydrate, because grip strength, mind you, is the fastest bedside marker of insulin sensitive muscle. If your grip strength is going down, your insulin sensitivity is going down. HbA1c tells you glucose history, but grip strength will tell you the metabolic future. Remember this. When grip improves, insulin resistance actually retreats and you start losing weight. Well, this is about hand grip. And another very important thing that we look at is, and we don't look at, is actually the gut microbiome. The gut microbiome is one of the most important things of your body. Remember this, you have more bacteria than you are human being. Okay, that's the amount of bacteria you have inside your body. There are trillions. There are trillions of these organisms in your body. Well, each of those organisms in your body play a very important role when it comes to fat loss. Well, if there are short-chain fatty SCFA producers that are on the lower side, then you probably have to start with proteins plus fats, add soluble fiber gradually, and delay starch escalation. It tells you certain things. These particular things tell you something so that you can lose weight. Butyrate producers actually, if they are low producers, we can actually add incremental fermental fibers before starch and avoid refined carbohydrates. So this is something you can do when you find these problems. Similarly, if there are LPS producers, it's very important for us to actually have omega-3, polyphenols, curcumin, low food map fiber initially. And if there are bile acid metabolism microbes, again it's a low producer, you need moderate fat, not very high fat, and add bile supportive foods. Importantly, if your gut is not diverse enough, you're probably not going to lose weight at all, and you need to go very slow on your diet routines. So there are a lot of things that the gut microbiome, I've just told you a small snapshot of what happens in such cases, but there's a lot more things that you can do with the gut microbiome, and actually a person who can interpret that gut microbiome much better than what it is. So in short, this is what the gut microbiome really does. Remember this, in obese diabetics, fix the microbiome, else nothing may work well. It's important to fix the microbiome. If you do not do that, it is not going to help your obese diabetics. Well, let's go to the final thing that I say, which I feel probably holds the crux to everything, and that's indirect calorimetry. There are a number of physicians in this, and physicians, we know we like goal-directed therapies. We have a lot of goals that we have, and Vishal, you'll agree with me, we've had goal-directed therapy on everything. We've had goal-directed therapy on echocardiography, on resuscitation of patients, on ultrasound. We have goal-directed therapy on everything. And surprisingly, we don't have goal-directed therapy in nutrition, if you ask me. There is nothing like goal-directed therapy. So the answer to every time is to provide precise energy, to encourage anabolism, to ensure safety of delivery, and to improve overall outcomes. This is actually the 4 tenets when it comes to nutrition. And let's understand again, how can I provide precise energy much better than what I did till now? In the obese individual, let's take a clinical case. Now we are in a hospital, so rather than actually going back to obesity, I'm going to do a clinical case. Okay, this is a clinical case where on day 0, you have this obese individual who came in with a road traffic accident with a subdural hematoma. Okay, he was operated for a traumatic brain injury. He was weaned off the ventilator on day 3, and on day 7 he was made to walk and shifted out of the ICU. Mayur will agree that this is a very straightforward case that actually occurred, and what we would do in this case, all of us know. 25% of the resting energy expenditure, then 50% of the resting energy expenditure, and then 70% of the resting energy expenditure. This is simple, very simple, but our intensive care patients are not like this. They are actually like this. So if they come this way, then they have a whole lot of things that happen. Normal BP, then they're tracheostomy, they're weaned off, they go into sepsis, they go into renal failure. They've got everything that occurs in this particular patient. How the hell can you have one particular number in these patients when it comes to calories? It's just not possible. It's just not possible. And that's why we need to make this precise. To make this precise, one of the things you can follow is something like this. In acute phase, less than 18 and then more than 10 kilocalorie, followed by 70% of REE. But then what do guidelines say? The guidelines say you start at 20 to 30% of the resting energy expenditure, 30 to 50% of the REE, and then 70% of the REE as the patient kind of gets better. Now the important thing over here I'm writing is REE. Lesser is better. The answer is REE. Okay, now let's come back to REE, okay, quickly. Well, and RE can be found only by using indirect calorimetry. Okay, so indirect calorimetry is the only way that you can figure out your resting energy expenditure. Are there studies that say that this actually works? Well, there are a couple of studies that say, this is the first study that I'm talking to you about. We did a analysis or randomized control trial of 100 plus patients who actually looked at indirect calorimetry, and what we found was that the length of stay actually came down in those patients in which we used indirect calorimetry. That means to say that resting energy expenditure, if you measure and not just estimate, and then prescribe your kilocalories, these guys actually live longer, and the length of stay actually comes down by around 2 days. Now tell me, everyone in this hall, if by any chance you're going to measure the blood pressure, then only you're going to treat the blood BP, isn't it? Similarly, if sugar if you want to treat sugar, you will first monitor the sugar, isn't it? Then only you're going to treat it. Why are we not measuring the kilocalories before actually we prescribing it? It's important that we measure the kilocalories that we have before we actually prescribe it. That's the important thing that I'm saying. How can you even prescribe the kilocalories without measuring? And the answer is to do indirect calorimetry. Remember this, prescription-based, equation-based kilocalories do not work. And this is another study that we did a while ago, which actually said that if you were to actually have equation-based kilocalorie requirements, they are all over the place. They are not precise. And the important thing is to make this precise. So what happens in a clinic? In a clinic, something like this happens. Both me and my brother were 100 kilograms. We eat 1,500 kilograms. He is losing and I am not. Is there something different? Yes, there is, obviously. This is the eat less myth. People just say you eat less, you move more, you lose weight. It doesn't work like that. Really doesn't work like that, because resting RMR changes between individuals. For example, let's take this. You have that 100 kilogram, 2 people who were there. They were given a 1,900 kilocalorie prescription. But what happens is that resting energy expenditure is different. The first resting energy is just 2,400 and the other is 1,500 kilocalories. Now this you can find out only if you do the RE by indirect calorimetry. There is no other way to figure out what is happening over here. You do that, the first one will lose weight and then the second one gains weight. As simple as that. So that is why you, in obesity, if you do not have an indirect calorimeter, probably you are not doing the right thing. It's important to have indirect calorimetry to figure out kilocalories in such patients. Well, if calories are not measured, nutrition is not precise. It's as simple as that. It is guesswork. Everything else is guesswork. Well, I'm on a diet, but it's just not working. This is something that comes in. I'm on a diet, but it's just not working. Well, that again comes from indirect calorimetry. We can understand why this happens, because 30 to 45% have suppressed resting energy expenditure. So if it's suppressed, even if you eat less, the expenditure is only so less that you do not actually lose your weight. The second thing is, many of them have an elevated RQ. When they have an elevated respiratory quotient, means even if you're fasting, you're not oxidizing fat, you're oxidizing glucose. So that means to say fat never goes off the body, glucose only goes off, fat never goes off, you just get tired. So many people fast and they get tired. These are those individuals whose respiratory quotients are very, very high. Well, 70% have adaptive thermogenesis. The first speaker did allude to this a while ago, where you diet, you lose weight, and then you stall. You stall because of the fact that you go into adaptive thermogenesis. Adaptive thermogenesis is a mechanism that can be detected by indirect calorimetry, and there are certain measures that will get you back to that level where you again start losing weight. Okay, so 70% have adaptive thermogenesis, and that is why they refuse to lose weight. And to find this, the only way is to figure out that metabolic mismatch using indirect calorimetry. It's very essential that we know that. So in short, obesity is not a disease, it is a metabolic phenotype. I would call it a metabolic phenotype, and RQ, I feel, is the missing link, even in such cases where he says, I've lost my weight and I've gained it all back. This will occur if the RQ kind of changes, because RQ change causes insulin resistance, a poor metabolic flexibility, and a chronic carbohydrate dependence. And there are methods to improve that RQ. And that is what unless you measure it, you'll not be able to do what is to be done with it. Yes, you need to precisely know the RQ to ensure that the diet remains working. That is very important. And when you actually open up the indirect calorimetry report, this is how it looks. This is exactly how the indirect calorimeter looks. And if you have, this is precision nutrition at its peak, if you ask me. That is where the RQ lies. That's where how much substrate utilization takes place, carbohydrates, fats versus proteins. And that's where your kilocalories are, 1750. So does it really make a difference if you use this? I mean, if it was commonplace, then the whole of India should have had it, is what you'll feel, isn't it? But things come, things evolve, and we learn. And people have learned all the way. Now, this is one trial that was done of 50-odd patients, where indirect calorimetry was done every 4 weeks, and the diet was kind of changed. Adjustment of diet based on metabolic changes and substrate utilization and a dietary counseling. What happened was very clear. 2.3 kilogram more weight loss was seen. 3.9 centimeter more reduction in waist was seen circumference in the IC group, clearly showing us that doing IC works. I mean, it's not possible to actually lose weight judiciously and precisely without actually doing indirect calorimetry. Let me take you to another very beautiful paper that was done by the University of Arizona Collaboratory Lab, Metabolic Lab. The 40 subjects, type 2 diabetes, BMI was 37 was the average. And what happened? Look at this after they used indirect calorimetry. Those patients who were monitored using indirect calorimetry and diet adjustments, they lost large amount of weight. Not only did they do that, even their HDL kind of changed, indicating cardiometabolic health gets better. So importantly, if you want to lose weight judiciously, it's important that we use indirect calorimetry, because in this study, 45% of the patients received a calorie recommendation from the equation that was 40 to 90% higher than the actual. So if you use an equation, you might probably end up eating a lot of food rather than, if you don't, you may not require it itself. What it does actually, what does indirect calorimetry does? Obesity is not a calorie problem, it's a metabolic phenotype. Indirect calorimetry makes this invisible visible. And that's what we need to do in these cases. And that's why in an obese individual, BCA, CPET, indirect calorimetry, hand group dynamometry, and gut microbiome. If you put all of these together, you can make nutrition very, 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 very precise. And if the topic given to me was actually to make this nutrition as precise as possible, and this is the only way we can do that, because this is what will help all our patients. With this, we can provide optimum energy, encourage anabolism, safety of delivery, and improve overall outcomes. Thank you very much. Thank you very much for the patient hearing.
Very nice lecture, Dr. Sanjeev. Thank you so much. The forum is open for any questions from the audience. How do we change this, whatever guidelines you have given to us, into our day-to-day clinical practice?
So, first, you're opening up an obesity clinic. You probably should encourage the management to actually invest in certain machines which will actually help. Obesity doesn't work by saying, eat less and move fast. It doesn't work like that. If that was the case, then cows would not remain so fat. They eat only grass. So that way, oh no, each of these machines are very expensive. They're quite expensive. But then worldwide, if you go to the Mayo Performance Clinic, you go to various clinics across the world that looks at obesity, this is how it is done. This is how it is done. We are doing it, yes. Anyone who wants to come and have a look at it, please come and have a look at it.
I got it done, but it's very difficult to read. I didn't understand. It was really nothing to read. What do I have? Sarcopenia or fat or what I have? It's very difficult. It's only if you're born into depth you will understand this report.
So I recommend you all to once pay a visit to True Peak Health. It's in Dadar. We have all of these things over there. You can come and have a look.
So the gut microbiome analysis and all those things are
yes,
done there.
This what I showed you is what we are doing. It's not something that is just there from Western literature. This is something that we all are doing.
Excellent.
Yeah.
Professor Sanjeev, good afternoon, sir. So Hippocrates has said that all diseases begin in the gut. And that's why gut is called the second brain.
Correct.
That's one thing.
Correct.
And secondly, so nutrition has become a religion with too many saints, each one obsessing over one nutrient while blaming the other. So I mean, which path do we take, Where do we go?
Frankly, if you ask me, this is one of the most unregulated fields in the history of medicine. Nutrition is the most unregulated field. It starts from training. Remember, these doctors are not trained in nutrition. Dietitians are trained in nutrition, but unfortunately, they don't have councils to regulate everything. So overall, it is one of the most unregulated field that comes in. Every person who looks good, feels good, talks well, becomes an influencer and starts telling you, eat this, eat that. It doesn't work like that. It actually requires a lot of knowledge of physiology, a lot of knowledge of anatomy to understand whether this is right or that is right. Yeah.
You have a clinic in nature like this?
I have a True Peak Health. No, here at Dadar.
Hello. Hello.
Yeah. See, so it's such an important question that you asked, that how do you actually take care of sarcopenia? So you've asked two questions. You've asked two questions. How do I eat the number of protein, and how do I preserve sarcopenia? These two are very, very interlinked. So to preserve sarcopenia, one of the most important things is to move well. Now when I say move well, it means you have to do those kind of exercises that are resistance-based exercises, which will allow you to do those. For example, you do a CPET training, we'll know where you are at. So we'll tell you at this heart rate is where you're supposed to move so that your muscle mass goes higher. Intelligent supplementation with a large number of supplements, that is if you require it, after doing a muscle sound, we'll know exactly what kind of supplements you'll require, maybe creatine, maybe HMB, maybe any of the supplements that you'll require to get the muscle up, including resistance training. And for vegetarians, it is definitely a task. If you ask me, it's definitely a task for you to take that up. The only way you can do that is by actually supplementing yourself with whey protein. I mean, this is the only way we can do it. And it's important because if you have sarcopenic, you actually lose longevity, you actually lose quality of life. And that's why first measure and then treat. That would be the answer.
Okay, thank you. Is it okay to take whey protein long term?
Absolutely, it's a completely easy, most bioavailable, easily assimilable protein. 20 grams, 3 times in a day is also fine. People take 40 3 times in a day.
Okay, thank you.
As we go on
Correct.
aging, so we have a bone loss. That
Correct.
is going to happen in
Correct.
a geriatric. Same thing happens with the muscle.
Correct.
Because the muscles have to atrophy.
Correct.
So that what they are asking, ki with food your muscle will come back.
No, it will not.
No, it doesn't come.
It will not come
It
back.
depends at which age you catch the patient. If you ask a 80% or 90 people your age, they will not improve
So
their
the
sarcopenia.
answer is so simple, you normally prepare for the future. So when you are capable to do strength-based training, when you are capable to digest that kind of food, you probably want to do that so that as you age more better, you don't lose mass, and even if you lose lesser than the others. So it's like a bank balance. It's your health is your bank balance.
Maybe for the want of time, we'll close the session. We can have a personal question with Dr. Sanjeev. Thanks, sir. Excellent.
Thank you for the interesting lecture, sir. Your presentation speaks volumes about your keen interest in nutrition and its clinical importance on a molecular level. I now request Dr. Mayur Mewada, sir, to please felicitate Dr. Sanjit Sasidharan, sir. Moving on to our fourth lecture for today, I have a question for you. Can obesity cause cancer? Yes or no? Yes, okay. I would still want you to hear it from the specialist. So please let's call Dr. Rohit Pai, sir, for the lecture.
Good evening. Thanks to Dr. Mayur Mewada for the invitation, and he's a dear friend and colleague, and I think we had some of our seniors. Dr. Yevlekar sir was my dean. I am MBBS from Sion Hospital. Dr. Girish Ajay sir is my current HOD in Nair Hospital. I work in the Department of Medical Oncology there. And I'm basically a consultant medical oncology. I visit Somaiya Hospital, but mainly work in Bombay Hospital and now recently in Glen Eagles also. So the first thing is that when Dr. Mayur mentioned that you have to give a talk on obesity and cancer, and I mentioned it in my home that I was going to go and give the talk, my mom said ki thoda वजन कमी करून जा, बरं नाही वाटत. ठीक आहे, ओबेसिटीवरती टॉक देणारा माणूस एक मोठं पोट घेऊन जातोय. सो द थिंग इज आय हॅड ओनली 2-3 months I did not take these GLP-1 and agonist or something like that. I tried to cut down on certain foods in my diet. We had a talk on diet, but yes, so here we are. I tried. So the thing is that obesity and cancer. So this is the outline. Per se, this is the only talk today which is having an allied sort of speciality. Other talks are having like focus on obesity, and I would not be boring you with too much chemo and exotic stuff. Okay, this is not meant for, this forum is not meant for that. What I would like you to realize is what are the various things which are the talk of the town in cancer and obesity research, and what are the things which are still not clear, that how does obesity affect cancer. So this is the outline. between obesity and cancer. So the first is association, second is obesity interaction with cancer detection and treatment. Third is cancer survivorship, focus on exercise and physical activity. Fourth is therapy of obesity and its impact on cancer. And last is obesity and cancer prevention. And I would like the organizers to just warn me when I have 5 minutes remaining, okay, so that I can get it done with. Because as oncologists, we have a tendency to keep on rambling on about various drugs and all that. So association between obesity and cancer. Okay. There are 13 obesity associated cancers. So this is something which you should all know about. So right from the top, meningioma, thyroid, esophagus, breast, multiple myeloma, hematological malignancy, pancreatic cancer, liver cancer, gallbladder cancer, colorectal cancer, gastric, cardiac, so gastroesophageal junction is the ideal terminology, endometrial cancer, renal cancer, and ovarian cancer. So these are the 13 cancers which have been established to be associated with obesity, and this was essentially a New England Journal of Medicine paper. And it was given by the International Agency of Research in Cancer, IARC. So this was a position paper. And there are certain unexpected names in this. So no one would think multiple myeloma would be related. Okay, meningioma would be related. But yes, there are certain expected terms. But if you look at the hazard ratio, if you look at the risk, endometrial cancer 7.1 times, esophagus 4.8 times, and the other GI cancers come below that. So there are certain cancers which are exquisitely associated with obesity. You have heard of corpus cancer syndrome in endometrial cancer. So it is an association of obesity, hypertension, diabetes, and endometrial cancer. So again, this just shows why it is it is actually a syndrome, because endometrial cancer is one of the cancers which is exquisitely sensitive to changes in body fat. Epidemiology. High BMI may cause up to 5 lakh cancer cases per year. 4 to 8% of all cancers are attributable to obesity. And cancer-related death due to obesity, around 20% in women, 14% in men. So very important is, obesity is a very important risk factor and is contributing to cancer morbidity. What is the pathophysiology of obesity causing cancer? Now this is a very busy slide, but essentially just to point out certain things. So you have chronic inflammation. Obesity is a sort of a pro-inflammatory state. And again, that is one of the reasons why you have accelerated atherosclerosis and all these other things also. It is not just cancer. You have altered immune function. You have increased oxidative stress, damage of DNA. You have insulin resistance and hyperinsulinemia. You have things like coagulation activation, epithelial mesenchymal transition. So what is that? So once you have epithelial cancer, it tends to lose some of its characteristics and tends to behave like mesenchymal cells, and that increases the risk of metastasis. So that again is sort of promoted by obesity. Sex hormones, adipokine imbalance, altered gut microbiota, hypoxia, and VEGF activation. So, and these are some of the factors which are leading to cancer. And what is important in this especially is the immune inflammation, the oxidative stress and damage, and the hormonal changes. For example, the classical example is postmenopausal breast cancer. So in a premenopausal lady, what is the source of estrogen? In a premenopausal lady, what is the major source of estrogen? Ovary. Okay. So once the menopause happens, ovary will simply stop working. That is the definition of menopause. But still there will be some sex hormones circulating. So what is the source of that? So you have adrenal glands, you have extra adrenal tissues like fat, like liver, like muscle, leading to hormones being generated. So you have essentially an enzyme called aromatase, which converts the steroidal precursor, the androgenic precursor, to estrogenic molecules, and these can again drive the carcinogenesis, especially for hormone receptor cancers in a postmenopausal lady. Okay? That is why we have certain drugs called aromatase inhibitors, जो ये aromatase को कम करेंगे, जो ये androgen to estrogen precursor, androgenic precursor to estrogen का conversion कम करेंगे, which only work in postmenopausal ladies, don't work in the premenopausal ladies. And that is the reason postmenopausal breast cancer is associated with obesity, especially hormone receptor positive breast cancer. There are other examples. You have altered gut microbiota in colorectal cancer. Again, microbiome is something which there can be another talk about. So as your body composition changes, your microbiome changes, and again, certain good bacteria and bad bacteria might contribute, an imbalance might contribute to carcinogenesis. Mechanistic effects. पेट ज़्यादा है, बड़ा हुआ है, you will have increased acid reflux. Gastroesophageal junction tumor का pre-malignant condition क्या है? Barrett esophagus. So Barrett esophagus will be developed and it can lead to cancer. Gallstones and metabolic alteration, especially the bile composition will change as if your body fat composition is changing, especially true for gallbladder cancer. And again, hormonal influence in endometrial cancer. Endometrial cancer भी क्यों हो रहा है? Postmenopausal ladies में progesterone will reduce the epithelium का proliferation and estrogen unopposed will increase the estrogen का endometrium का proliferation. And same concept जो breast में है वो endometrium में भी लागू हो रहा है, right? अगर ज़्यादा fat है, ज़्यादा estrogen है and ज़्यादा epithelial proliferation in endometrium हो सकता है. Obesity interaction with cancer detection and treatment. Now, cancer screening के लिए obesity is a very important sort of barrier. Now you only think there are barriers with the patient and barriers with the doctor. So this is a systematic review of obesity as a barrier to accessing cancer screening services. Patient-reported barriers: modesty, embarrassment, fear of pain, competing demands on time, belief of being at low risk of developing cancer, lack of awareness, and previous negative experiences in screening. Because screening camps etc. time bound condition में रहते हैं, time bound situation में रहते हैं. एक obese patient आया, time ज़्यादा लगता है, the healthcare staff also gets irritated and you can have a negative sort of impact on the patient psyche. Healthcare reported क्या है? Lack of knowledge and difficulty in performing examination techniques. अभी एक pap smear के लिए gynecological examination table, lithotomy position वगैरह लगेगा. Obviously obese patient के लिए अलग से आपको arrangement करना होगा. Lack of equipment, lack of resources. Patient size may affect the mammography efficacy and safety because you may have a pendulous breast, you may need to reposition your screen films. Health and safety issues, difficulty in discussing weight. So basically दोनों जगह से barrier है, patient के तरफ से भी and doctor के तरफ से भी. इसलिए screening obese patients में नहीं हो रहा है. मतलब patients नहीं, obese individuals में नहीं हो रहा है. That is the reason why the cancer may be detected late. What about cancer detection in general? Radiological investigations like ultrasound will be less sensitive in obese patients. It's a simple logic. You will require higher X-ray doses to determine what is going on. You will have a difficulty in getting a tissue sample. Does everyone know from where a bone marrow biopsy is done? Students? Bone marrow biopsy is done from? It used to be done from here, manubrium sternae, but now it is done from the posterior superior iliac spine. Now you imagine a obese patient, posterior superior iliac spine is under layers of fat. Bone marrow examination के पहले हम लोग को periosteum तक infiltrate करना होता है local anesthesia. एक needle का size कितना है? जाएगा क्या है periosteum तक? और अगर नहीं गया तो pain होगा patient को. Patient won't cooperate, you won't get a sample. We sometimes have to use lumbar puncture needles to actually go in and infiltrate the periosteum and get a sample. So essentially you have difficulty in biopsy. Similarly, एक CT guided biopsy करना है lung mass का, true cut biopsy अंदर जाके करना है, obese patient, it is difficult. Difficulty in accommodating and shifting the patients. यहाँ पे कुछ लोग third minor, third major, second year में हैं. जब intern बनेंगे, accompany the patient बोलेंगे, तो you will realize that obese patient being transferred to a CT scan MRI, how difficult it is. कितने लोग रखते हैं, कितने मामा मौसी का मदद लेना पड़ता है, and how uncomfortable it is for the patient. Interference of concomitant medicines in tests like PET CT. एक PET CT करने के पहले FDG PET, fluorodeoxyglucose PET. In general, what are the instructions you give to the patient? Anyone? Blood sugar. या बट पेशेंट को क्या बोलते हैं? पेशेंट को फास्टिंग फॉर 6 आवर्स, ठीक है, क्रिएटिनिन लेवल होना चाहिए बिकॉज बहुत बार कॉन्ट्रास्ट देते हैं. द थर्ड थिंग इज you have to ensure that the patient does not take the anti-diabetic medicine in the morning. Because FDG PET में अगर आपने गलती से anti-diabetic medicine दिया तो जो FDG है, ग्लूकोज है essentially, वो अपटेक मसल वगैरह में चला जाएगा because that is the mechanism of action of the oral diabetic agents. So basically morning sugar should be less than 200 milligram per deciliter. नाइट का ही इंसुलिन आपको ऑप्टिमाइज करना है या एंटी डायबिटिक कंट्रोल ऑप्टिमाइज करना है. सुबह में शुगर ज़्यादा है देख के भेजो नहीं, दैट विल एक्चुअली इंटरफेयर विद द टेस्ट. सो एक्चुअली देर इज इंटरफेरेंस. पेट सीटी इज लाइक CBC, RFT, LFT नाउ इन कैंसर पेशेंट्स. अनफॉर्चुनेटली ऐसा नहीं होना चाहिए बट इट इज देयर, इट इज द ट्रूथ. सो इट इज इंटरफेयरिंग विद द टेस्ट एंड रेयरली कैंसर कैन प्रेजेंट विद ओबेसिटी. सो यू कैन हैव अ एड्रिनल ट्यूमर, like I think it was discussed secondary causes of diabetes में Cushing's वगैरह discuss हुआ था, and you can have a paraneoplastic Cushing's, okay, because of ectopic adrenal ACTH production in RCC, lung cancer, etc. Now what about cancer surgery and radiotherapy? There is increased technical difficulty in surgery, but obvious आपको बहुत ज़्यादा अंदर जाना पड़ता है. You have increased dissection, visceral obesity की वजह से you have increased manipulation, simple, increased blood loss. पोस्ट ऑपरेटिव इशूज़, कार्डियक एंड रेस्पिरेटरी कॉम्प्लिकेशन बहुत कॉमन है ओबीज पेशेंट में. DVT बहुत कॉमन है ओबीज पेशेंट में. पुअर वुंड हीलिंग ऑब्वियसली बिकॉज जितना आपका लेयर्स ऑफ एब्डोमेन ज़्यादा रहेगा उतना हीलिंग का टाइम बढ़ेगा. प्रोलॉन्ग हॉस्पिटल स्टे, डिफिकल्ट मोबिलाइजेशन, पेशेंट को एम्बुलेटरी करने में वगैरह, फिजियो वगैरह करने में डिफिकल्टी होती है. एंड डिफिकल्ट सेटअप फॉर रेडिएशन. अगर रेडिएशन देना है तो भी मशीन में डाल के इमोबिलाइज करके देने के लिए you require time in an obese patient. Even though now modern techniques like IMRT and IGRT, intensity modulated radiotherapy, image guided radiation might mitigate, but it is difficult. What about chemotherapy or systemic therapy and obesity? Basic issue, venous access, vein नहीं मिल रहा है. Breast cancer patient में MRM के बाद that limb usually is not used for giving chemotherapy. You have only one limb. और उस पे से पेशेंट ओबीज है, बहुत मुश्किल हो जाएगी. द सेकेंड थिंग इज कीमोपोर्ट डालना पड़ेगा, पिक लाइन डालना पड़ेगा, विच विल इंक्रीज द कॉस्ट. ओके, डोज कैलकुलेशन, एक्चुअल बॉडी वेट लेना है, आइडियल बॉडी वेट लेना है, क्या करना है. सार्कोपिनिक ओबेसिटी बहुत इंपॉर्टेंट. ये बोलते हैं ना थिन आउटसाइड फैट इनसाइड. सो मेनी ऑफ आवर इंडियन पेशेंट्स आर एक्चुअली दिखने में गोल मटोल. दैट वाज द टर्मिनोलॉजी यूज्ड बाय वन ऑफ द स्पीकर्स आई थिंक अर्लियर. But actually you have low muscle mass, so you have sarcopenia and that can increase the risk of chemotoxicity. Then you have cardiotoxicity. Everyone has heard of HER2 positive breast cancer, anti-HER2 drugs. उनका obesity के साथ clear cut connection है. Obesity increases the risk of cardiac toxicity of these drugs. And you have drug-drug interaction. Diabetes control करने के लिए वगैरह बहुत सारे मेडिसिन चल रहे हैं. आप oral chemo दे रहे हो, oral hormonal treatment दे रहे हो, तो drug-drug interaction होने का ज़्यादा chance है. So this is the way obesity can impact systemic therapy of cancer. So this is again a very complicated sort of a table, but I would just like you to say that lymphedema, surgical complication, chemotherapy-induced neuropathy, post-chemo complication, cardiotoxicity which I just mentioned, radiation-related dermatitis, incontinence after surgery or radiation, surgical complications, all of them have been associated with obesity. And there are various underlying mechanisms, right from oxidative stress to excess, like for example, excessive skin fold during radiation, delayed tissue repair. So various mechanisms, but essentially all these complications have been associated and seen in observational studies with obesity. There is something called as obesity paradox. As in, some studies have shown that there is better survival in cancers like melanoma and renal cell carcinoma in obese individuals than non-obese patients. Hypothesis is obesity-related chronic inflammation may improve the effect of certain immune checkpoint inhibitors. Like obesity-related inflammation रहता है, आप inflammatory cell को stimulate करोगे by giving immunotherapy, and वो improved outcome होता है. But this is again not proven in other cancers like lung cancer. And there are various confounding factors like reverse causality. एक fat patient है cancer का, cancer will cause weight loss, and you will feel that the patient is becoming healthy. थिन पेशेंट का वेट लॉस हुआ, यू विल फील दैट द पेशेंट इज गोइंग डाउन, रिवर्स कॉजेलिटी. BMI कंपाउंडर, जो मैंने बोला, BMI में सिर्फ वेट और हाइट मेजर करते हैं, बट वो वेट में मसल कितना है, फैट कितना है, बोन कितना है नहीं पता, राइट? सो ये ओबेसिटी पैराडॉक्स है, इट्स नॉट प्रूवन, एंड ओबेसिटी कैनॉट बी कंसिडर्ड गुड इन कैंसर, प्लीज रिमेंबर. ओके, व्हाट अबाउट कैंसर सर्वाइवरशिप? पेशेंट का कैंसर का इलाज हो चुका है, पेशेंट अभी सर्वाइवर है, आगे क्या? So this is very important, focus on exercise and physical activity. So this was a large, EBCTG is a collaborative group in Oxford, UK. Early breast cancer trialist collaborative group. So they studied around 2 lakh patients in 147 trials with obesity. And this is very important. For every 5 kilogram per meter square increase in BMI, 6% risk of distant recurrence was increased. And it was irrespective whether the patient received chemo alone, endocrine treatment alone, or both. So hormone positive, hormone negative, kuch bhi hone do, obesity had an adverse impact, right? And physical activity is associated with around a 30 to 40% maybe a reduction in relative risk of certain cancer survivors, especially breast, colon, and prostate cancer, as far as this meta-analysis is concerned. There are benefits of exercise in cancer survivors and cancer patients beyond weight reduction and prevention of obesity. For example, cancer-related fatigue care treatment is physical exercise. This is thoda counterintuitive, but treatment of cancer, chemotherapy-related fatigue or cancer treatment-related fatigue is exercise, not rest. Health-related quality of life is improved, physical function is improved, anxiety is lessened, depression is lessened, lymphedema is reduced. So there are benefits of exercise in cancer patients beyond just prevention of obesity. This is a very interesting study, and I would like to take 2 minutes to describe. So this is a challenge study which was done for patients of colon cancer stage 2, stage 3, who have undergone surgery and chemotherapy. And this was conducted in Australia and Canada. And essentially, patients receiving sort of the entire treatment, completing the entire treatment, were first given a fitness examination. ऐसा नहीं होना चाहिए कि cardiac failure है, कुछ है, exercise नहीं कर पाएगा. And then they were randomized to a structured exercise program and health education material for 3 years versus only giving health education material कि ये करना है, ये नहीं करना है. उसमें around 900 patients were taken, median age of 60, and baseline characteristics में कोई फर्क नहीं था between the two arms. It was a randomized control trial, the first randomized control trial, essentially a big, large one. And what happened was, in the initial 1 year, 83% followed their exercise. Next phase 2 में 68%. So जैसे time बीत गया वैसे exercise का intensity कम हुआ. Musculoskeletal adverse effects with exercise थोड़े से ज़्यादा थे, 19% versus 12%. Obviously, न्यू ईयर में बहुत पब्लिक है जॉइन जिम, यू विल रियलाइज कि जल्दी जल्दी एक्सरसाइज करने में क्या हालत होता है. सो द पॉइंट इज मस्कुलोस्केलेटल एडवर्स इवेंट थोड़े से ज़्यादा थे, बट दिस इज व्हाट इज इंपॉर्टेंट. देयर वाज अ इंप्रूवमेंट इन ओवरऑल फिटनेस, मेट आवर्स पर वीक, VO2 max, 6-minute walk test, and this is the most impressive thing. The disease-free survival, the recurrence risk was significantly lowered. So you have a 7%, 6.5% disease-free survival difference between exercise versus no exercise. इतना कीमो का भी रहता है कभी-कभी, let me be honest. And with no actual per se, no great toxicity, you are having a disease-free survival benefit. And this was because the local recurrence was reduced, the distant recurrence was reduced, and also these individuals did not have second new cancers. So because they were physically fit, they were physically active, they did not develop second new cancers. So this was a challenge study, and this we are incorporating it in our practice. We are sending the videos to our patients so that they exercise after having completed treatment for colon cancer. Breast cancer के लिए भी there are various small studies. ये 900 patient का RCT था. There are around 250, 300 patient का studies है, START study, exercise for health, OPD train, which are again showing that incorporating exercises reduces cancer-related fatigue and also improves the outcome in breast cancer patients. What about treating obesity and its impact on cancer? Bariatric surgery was the old treatment. Nowadays, I think it's a not a good thing to talk about bariatric surgery on this forum, but bariatric surgery and weight loss were associated with around a 30 to 40% reduction in risk of certain cancers like postmenopausal breast, pancreas, colorectal and endometrial cancers in certain cohorts. And these are quite big numbers. If you see, the numbers are 22,000 bariatric surgery patients versus 66,000 matched controls. Now coming to GLP-1 receptor agonist, GLP-1 agonist basically, this is preaching to the choir. I am not an expert on diabetes, but essentially they have a lot of effects on the brain, the fat content, pancreas, gut, etc., leading to decrease, probably food intake, increase insulin sensitivity, and obviously they are one of the drugs which we are using in diabetes patients. Now, are they associated with a reduced cancer risk is the question. So this was a large study. TriNext platform is essentially a collaborative platform which reports the various outcomes for patients, John Hopkins based. So in this, actually look at the number of patients who have over 1.6, so around, not 1.6, so you have around 16 lakh patients who are eligible for GLP receptor agonist, and they were either prescribed GLP-1 agonist versus insulin and metformin, and they were sort of analyzed for cancer. And essentially, most of the cancer risk was decreased in diabetic patients receiving GLP-1 receptor agonist versus those receiving insulin or other medical management. Another study which looked at patients who were taking GLP-1 agonist for obesity, not for diabetes, again looked at the various cancers. So there was again reduction in many of the cancers associated with obesity, but again it's a work in progress. You cannot say that GLP-1 agonist will reduce the risk of cancer. I think more data is required. What about obesity and cancer prevention? Childhood obesity, gol matol bacche rehte hain, was the statement. And again, childhood obesity is associated with many cancers, especially endometrial, colorectal, very important. The youngest patient of rectal cancer which I am treating right now is aged 24 years of age. Rectal cancer, etc., is very common in young people, please remember. And one of the factors is bad diet and environmental influences like childhood obesity, please remember. And there is association between physical activity and reducing risk of cancer. So this was 1.4 million individuals in US and European cohorts. They were followed up according to their physical activity status, self-reported, and they showed that higher levels of physical activity was associated with lower risk of breast cancer and 12 other malignancies. So if you are physically active, you are reducing the risk of cancer. If you target childhood obesity, adult cancers might be reduced. So just to summarize, obesity is an important risk factor for cancer. Obesity interferes with cancer detection and treatment. So we spoke about chemo, radiation, surgery. Physical activity is very important to prevent cancer recurrence, especially in colon cancer survivors. And GLP-1 receptor antagonists are a work in progress as far as cancer is concerned, but some studies may show a benefit as far as cancer risk reduction is concerned. Thank you.
Thank you so much, Dr. Pai, for that interesting lecture and going beyond the risk factor, how to improve the quality of life and how obesity will affect the cancer itself. Now I'll open the forum for questioning, if there are any questions. Thank you so much, Dr.
No questions
Pai.
closed. So, ma'am. Mayur sir ka lecture is pending, na? Chalo, thank you so much. Bye.
Thank you, sir. We would like to felicitate you. I would request Dr. Narvika sir to please felicitate Dr. Rohit Pai sir. Thank you so much for the very interactive session, sir. I have a question for you all. Has any clinician experienced difficulty in treating diabetes, like as in treatment failure? I think at one point of time we all have. I would still like to invite Dr. Mayur Mewada sir to share his insights about treatment failures in diabetes mellitus and obesity.
Hello, a very good afternoon to all of you, and it is pretty much appreciable. I can see some people sitting from start to end. And with the kind of attention span that we adults have nowadays, this is really commendable. So, yeah. Thank you. So today I am here to talk about treatment failures in diabetes. It is a topic which is very difficult, and it is difficult because of 3 reasons I feel. The first reason is that we really do not focus on our failures, or we don't like to talk about our failures. We just want to keep boasting about our achievements. Second, unlike my previous speakers which came and went, they had a lot of statistics, they had a lot of guidelines, they had SOPs. But there are not much of SOPs to be followed when there is a failure. And thirdly, it's a difficult topic to talk about because I feel it has a lot of ethics, it has a lot of medical practices, a lot of behavioral practices from the doctor's end as also from the patient's end. So we will try to do justice to this topic, and we'll try to set a timeline for today's academic tour. So in the next 10 to 15 minutes, let us set the flow for the next 10-15 minutes. So we will see what is definition of treatment failure in diabetes and obesity. We will see what are types of treatment failures. We will see what are the causes of treatment failures and how to tackle the treatment failures. So let us go to 2 small cases. These are cases which all of us must have seen our routine practice. A 32-year-old male comes to your OPD with a report in hand showing HbA1c of 10.4, triglyceride of 445, LDL of 168, a serum creatinine 0.8, urine shows 3 plus sugars and 1 plus protein, and a BMI of 30.2. So how are you going to plan his treatment? Can any one of you, we have a lot of practitioners sitting here. So what is the drug of choice, or how you will plan his treatment? You will start some medicine, yes, sir? Okay, so sir's drug of choice is metformin along with a sulfonylurea in form of glimepiride. Okay, so you have started the medicine. I will not say whether it's right or wrong, but after 3 months of starting the treatment from you, he comes back to you again with a HbA1c of 8.9. And now he has lots of questions in his mind, and I am sure even the doctor has a lot of questions in mind that I did everything right, but why still the HbA1c is 8.9? So we'll come to the answer to these questions. We'll go to the second case. Here it's a 62-year-old female, type 2 diabetes for 15 years, well controlled with sulfonylurea and metformin, like sir's favorite I think, and a DP4 inhibitor. She has a good routine, regular exercise, good diet. In spite of this, now she has come to you in your OPD with a HbA1c reading of 7.9. Now, what shall be your plan of action in this patient? Yes. So, sir's answer is that we will add 1 more drug. Yes, you have added 1 more drug. But after adding that drug again, after 3 months, she has come to you with a HbA1c of 7.6. So, now what? Are you going to call both these cases a treatment failure? Yes, agreed. Yes, that is, we have to look for a lot of other parameters like lifestyle, but are we going to classify this as a treatment failure, both these cases? Okay, so the definition of treatment failure as per ADA says that a HbA1c of more than 7 gram% in spite of treatment is a treatment failure. So yes, both of these cases fall into treatment failure. But do you notice any difference between the treatment failure in the first case and a treatment failure in the second case? Both are treatment failures because the HbA1c is more than 7 after giving the best treatment as per us. So the first one, the young patient, we are dealing with something called the primary treatment failure. So what is primary treatment failure? That when the initial lifestyle changes or the medications don't control the diabetes. This is a primary treatment failure. The second lady, 62-year-old female, is a case of secondary treatment failure. So what is secondary treatment failure? That previously the oral medicines were controlling the diabetes well, but over a period of time, now the HbA1c has started shooting up and the oral medicines are unable to control the HbA1c. This is secondary treatment failure. So these are 2 different types of treatment failure. I hope we are in sync on this part now. Fine. So what are causes of primary treatment failure? So this is very important. As practitioners, we should know that when a person has come to us for the first time, are we doing the right thing with that person? So we don't want a primary treatment failure. disease severity, the single most factor. If the HbA1c levels at the time of presentation is high, more than 10 grams, or the age of onset of diabetes is a young age, then we are more likely to tackle a primary treatment failure. The clinical inertia, again, like I said, this is a difficult topic to talk because a lot of practice patterns, behaviors come into place. So what is clinical inertia? I want to be on metformin only. I want to put my patient only on one medicine. Okay, आप अभी नहीं आया अच्छा रिपोर्ट, आप 3 महीने बाद आइए, आप 3 महीने बाद आइए. So this is clinical inertia. So we have to be smart enough to not have a clinical inertia. And if somebody has come with a HbA1c more than 7, we should start thinking, should we intensify the treatment? Next is inclination towards monotherapy at a starting point. So many times we have a habit that अरे आपका कितना भी 500 शुगर है ना, ठीक है, मैं एक गोली से आपको अच्छा कर दूंगा. Okay, no, don't hesitate to start a patient on polytherapy or combination therapy. And lifestyle factors like obesity, lack of exercise, what sir said is right. So these are important causes of primary treatment failure. How to tackle the primary treatment failure? The best thing what we can do is identify it early. So if somebody has come to us with a HbA1c of more than 7 in spite of treatment, then please start thinking, let me add a medicine, let me do something, because my target is to keep it less than 7. Consider shifting to combination drugs like we discussed. Improve patient education. So many times this is a factor which we don't take care of, because see, patients are not doctors. Though we are in our flow of thoughts that we are doing everything right for the patient, there can be a possibility that patient is not understanding his or her illness or the importance of the medicine what you are writing. So we have to educate the patient. Simplify the regimen and address the cost. This is also very important. A too complicated regimen is not followed very well by the patient, or if it's a costly treatment, many times they are not able to follow it. Causes of secondary treatment failures. As a clinician and as a diabetologist, this is something what we deal with. Okay, a secondary treatment failures. So disease progression by far, or progressive beta cell destruction, is the most important cause for secondary treatment failure. That means a patient previously well controlled with oral hypoglycemic agent is now we are not able to control that patient with the oral hypoglycemic agents. Second is, there is a complex interplay between insulin resistance and lack of insulin secretion. So there is lack of insulin secretion, at the same time there is insulin resistance because of obesity and other factors. So obesity becomes important again in both kind of treatment failures. Stress is a very important parameter which none of us can measure. Non-compliance to medications, lack of exercise. And here I will take a pause. When we talk of non-compliance to medications, very senior practitioner is here. No matter whatever good medicines you are going to write on paper, many times it can happen that the patient takes the medicines by his or her own will. I'll give you multiple of examples. You have written 1 gram metformin twice a day. The patient comes with an uncontrolled HbA1c. You will ask him, kya ho gaya? Should I write another medicine? Should I intensify the treatment? And if you dig further and you ask him, he will say, sir, मैंने एक ही बार खाया. क्यों? अरे वो मेडिकल वाला बोला ये तो 1000 पावर का है, मैं 2 गोली खाऊंगा तो किडनी फेल हो जाएगा, तो मैंने ये गोली एक ही बार खाया. So this is a classic example of non-compliance to medication. This can be alleviated only by giving a good counseling to the patient. Okay. Tackling secondary treatment failure, I will cut short this by the last line written here, that we want to explore newer medical options other than the medicines which act on insulin axis. Okay, with the grace of God, now we are in an era, we have newer molecules like SGLT2 inhibitors, we have molecules like GLP-1 agonists, which are not completely dependent on insulin axis for their action, and the future of medicines is there. Now we come to case 3. This is a 46-year-old male who comes to your clinic with complaints of easy fatigability, excessive snoring while sleeping. You find his weight to be 98 kg, a BMI of 29.6, and a blood pressure of 160/95. The lab parameters are showing a pre-diabetic range and borderline cholesterol and triglycerides. So what is the advice to this patient now? sleep study is a good advice, but now we are talking about therapy, sir. So what is the therapy advice to this patient? Yes, so one of the answers is that we want to advise lifestyle changes to this person, and perhaps a GLP receptor agonist is what sir wants to say. Antihypertensive treatment also, because the BP is high. So you have started the treatment. Okay, in the best faith of the patient, you have started the treatment. And after 6 months, he comes back to you. Now his weight is 99 kg. He has put on 1 kg more. And BMI has crossed the danger mark of 30. BP has come under control. The good part is something which is saving you as a doctor, that the BP has come under control. HbA1c 5.7, TG and cholesterol modest improvements. So what has happened here? What has happened? Yeah, you again, with the previous slide, you have asked whether he has followed everything that you have said, and he said, yes, I have done it. So is this a treatment failure in obesity? Can you define this as a treatment failure in obesity? Yes. So treatment failure in obesity is defined as failure to lose 5% of body weight in 6 to 12 months after starting lifestyle changes along with treatment. So we have started treatment plus lifestyle changes both to this patient. And still after 6 months, the patient has not lost 5% of body weight. So that is why now this comes as a treatment failure in obesity. So what do you do? What are the causes? So treatment failure is there. What are the causes? Causes can be patient related, can be healthcare system related. And while trying to see treatment failures, we want to know whether it's a true treatment failure or if it's a relapse. Okay, like all the speakers previously said that it's a chronic relapsing disease. So there can be a possibility of relapse also. Patient-related factors, these are important, that obesity is a biologically complex condition. It is a biologically complex condition where we have to understand that all of us are moving around with a elevated set point in the hypothalamus. So all of us have, by the virtue of epigenetics, by the virtue of constant environmental triggers, we have set a different set point for us. And we have to understand that unless we are going to target that set point, we are not going to lose weight. Or if we lose weight, we are going to regain it again. Okay, so one of the more important reasons is that we don't understand the biological complexity of the obesity. Other is the psychological barriers. A person with obesity is placed in a very, very unique condition where he or she has lots of psychological issues. And those issues starts right from their parents, blaming them for their diet, or their peers who are body shaming them, or their workplace which is body shaming them. So they are placed in a very different psychological condition. And unless you address those psychological barriers, you are not going to be able to help that patient. Then comes the behavioral patterns. Impractical diets. I will not eat for 3 days because I want to lose weight. Now this is an example of impractical diet. So they don't work. Okay. And the socio-economic factors, including the cost or lack of healthy food resources, and cost in particular, I feel, is important. Then comes the healthcare system related factors. So lack of holistic care. Today, what are we, like the previous speakers also said, influencer wants to treat obesity. Okay, a gym trainer wants to treat obesity. Somebody visiting a cosmetic clinic wants to treat obesity. Are they really going to be able to provide a holistic care to the patient? So unless you are going to provide a holistic care to the patient, it's very difficult. We will have treatment failures with the obesity. Okay. Second is the physician limitations. Your insufficient training or spending insufficient time with the patient or having biases towards the treatment. These are important reasons for treatment failure. Then comes the medication side effects. A person with obesity by default has multiple comorbidities, and by virtue of that, he or she is on multiple medications. So there can be medicine side effects which we are not taking care of. And lastly, system or logistical issues like unavailability of the services nearby you, or not getting covered in the insurance. These diseases don't get covered under the insurance. So people are hesitant to take treatment. The moment they get covered under insurance, everybody, I'm sure, will start being more sensitive towards their needs towards obesity. So what are the keys? This is the last slide, luckily, for all of you. So what are the keys to successful obesity treatment? One is that we should have a multidisciplinary team. So unless one man cannot treat obesity, I cannot stand here and say, I will treat obesity. It has to be a multidisciplinary team, which involves dietitian, psychologist, and physician. And role of each of this is well defined. We just have to make a good team, multidisciplinary team, and follow it. We need to have a holistic approach. When I say a holistic approach, I'm just not going to treat the weighing machine, you know, that every time you stand on the weighing machine, your weight has to be less. I want to treat the entire body of the patient. I want to treat the entire physiology of the patient, the entire biological complexity, what we are talking of. We want to treat that. Long-term perspective, that we need to understand that there is no crash course in weight loss. It's not like, you know, I will do dieting, I will do exercise, and I have my plan for next 1 year, but after 1 year what? So this has to be a holistic approach. It has to be followed lifelong, and it's not a short-term vision. And lastly, we have to address the stigma. Unless you address the stigma, unless you combat the negative attitudes that a person with obesity has, it is very, very difficult to provide benefit to that person. Having said this, I would thank you for listening to me patiently. Thank you.
Thank you, Dr. Mohir, for that interesting lecture, and you made it resident treatment very simple. Thank you. Any questions from the audience? I think we have still some 5 minutes left for the questions.
Hello. There are no questions means either the speakers have done a good job, or all of you want to leave, or all of you are sleeping. I am not seeing anybody sleeping. So at least I hope that the CME served the purpose and all the speakers were able to help you in some or the other way. Thank you.
I would now request Dr. Niharika Gill ma'am to please felicitate Dr. Mayur Mewada, sir. So has worked tirelessly in conducting and planning this CME since a long time. Thank you so much, Gill ma'am. I would now request Dr. Mayur Mewada, sir, to extend his thank you towards the audience.
Hello. I would like to thank each and every delegate who has come here to bless us and make this event a huge success. We have had more than 250 delegates who have attended this CME today, which in itself speaks for all the speakers and all the efforts that we have taken to conduct this CME. Unless delegates come and give their blessings, it is very difficult for us to maintain our motivation. So a big thank you to the delegates. A big thank you to our management, our dean, our CEO, our HOD, who has always shared her blessings on us. The special dignitaries, you know, I would like to say they were everybody with man of wisdom, and they have given some wisdom by coming here. And lastly, the entire organizing team, the volunteers who always, the youngsters who keep giving us the energy to carry on. And it's incomplete if I don't thank our sponsors who have been very helpful. Every academic effort needs some money also. So Alnish Pharmaceuticals, Intas, IPCA have been very kind enough to give their support to us. Thank you. God Almighty bless all of us. Yes, yes, हम मिले हैं ना सर. Yes, yes.
I'd like you to attend.